The handouts or review materials must be treated with utmost confidentiality. It shall be the responsibility of the person whose name appears therein that the handouts or review materials are not photocopied or in any way reproduced, shared, or lent to any person or disposed in any manner. Any handouts or review materials found in the possession of another person whose name does not appear therein shall be prima facie evidence of violation of RA 8293. Top-notch review materials are updated every 6 months based on the current trends and feedback. Please buy all recommended review books and other materials.
Good day, Top-Notch Batch October 2023. I'm Dr. Kevin Ilomina and I will be your main lecturer for pathology. So some disclaimers before we begin this video and some reminders, no? So you've been warned. This is a long video ahead and pacing is key. No, whenever you have to engage in a very long activity, pacing is key. So you have to maintain your energy level at such that you can sustain longer hours. And hindi naman isang araw lang ang patho, no? I think it's divided. A week is allotted for the whole subject. So pacing is key, and you can spread your readings and watching of the videos over the week naman, no? Hindi mo yan kailangan lahatin. Kasi kahit ako, no, honestly, hindi ko yan kayang i-film ng one day, no? Kasi vocal cord nodule na tayo niyan, no? Okay? Now, also, this is quite long because I've included everything in the handout, no? So, para siyang walkthrough. So, para siyang magiging walkthrough ng buong handout. So, pwede nyo siyang sabayan, no? But I have skipped some parts. And itong mga parts kasi na to, pwedeng low yield yan. Or pwedeng recall information like, kailangan mo talagang tandaan, commit to memory lang, ganun. Walang explanation. Or self-explanatory. I believe your intellectual capacity, guys. Kasi nakatapos kayo ng med school, nakarating kayo sa point na to, you have what it takes to be a doctor. It's just that wala pa kayong lisensya. And ito nga yung ipinaglalaban nyo ngayon, diba? Now, we have 27 chapters. And yeah, that sounds difficult. But there are core chapters, and ito yung cheat ng patho, no? There are core chapters that you really, really have to memorize, or hindi naman memorize, no? Mali pala. You really, really have to master, no? In order to master everything. So those are 5 chapters, no? Your cell injury and death, your inflammation and repair, your hemodynamic disorders, your diseases of the immune system, and your neoplasia, all of which are in the first half, no? The first 9 chapters, and those belong to your gen path. Okay? So, pag na-master nyo yon, pag pumunta kayo sa systemic path, ibalik nyo lang yung explanation nyo, gawin nyo lang in terms of the general pathologic basis, no? Yung concepts nun. And then, madadaanan nyo ng mabilis yung systemic path, no? Basta alam nyo to. Okay? And I know that the devil's in the details, no, is an idiom with a different meaning, but this one is a lyric. This one is a line from Taylor Swift's Peace song from her album Folklore. The devil's in the details, but you got a friend in me. And parang yun yung relationship ko with patho. And I think yun din yung magiging relationship ng mga tao with patho. No, in general, it's a very detail-oriented subject. No, it's broad. It's complicated. But if you master your path, then it's going to be your friend, and you're going to have a really easy time with the other subjects, no, in the board. So this one, kailangan mo siyang effortan, kailangan mo siyang pagtuunan ng pansin, kailangan mo siyang pagtuunan ng panahon, pero magiging worth it siya in the end because magiging sandata mo siya not just in patho but in all subjects. Okay? So that's how important patho is. Okay, in the PLE kasi it's the bridging discipline ng lahat. Okay? So with that in the way, let's start with your lecture proper. Start tayo with cellular responses to stress. So there are many causes of your cell injury. Nakalista naman yan dyan. So let's go to reversible cell injury. Pag sinabing reversible, pag tumigil yung stimulus, babalik sa normal yung cell. And we have two consistent features, your cellular swelling and your fatty change. Now, yung cellular swelling natin, ang nangyayari dyan, your sodium-potassium ATPase pump, nagfe-fail yon because of ATP depletion, no? And ang nangyayari, the sodium comes into the cell, no, and it brings with it water, kaya dumadami yung water content inside the cell, kaya siya namamaga. Okay? Example is a swollen renal tubular epithelial cell, no, shown here. And then yung fatty change naman, the toxic injury targets the metabolic pathways that deal with lipid metabolism such that it favors, no, yung storage of your triglycerides in the form of your cytoplasmic vacuoles, no, of your fat. Okay? Like this one in your fatty liver. Yung cellular adaptations naman, we have 4, no? First off, we have hypertrophy. Pag hypertrophy, increase in the size of something. So, walang increase in number, there's only increase in size. And the stimuli include increased workload and hormonal stimulation. So, it does so by increasing the protein synthesis in your cells. So, example here is your hypertrophic cardiac myocytes in your hypertensive heart disease. So, if you have hypertension, ang nangyayari, you have increased workload on the ventricles, and the ventricular cardiac myocytes will increase in size like this. Okay? Now, for your hyperplasia, it's an increase in the number of something, no? Or increase in the number of cells, okay? So, it does so by increasing, by hormonal stimulation. So, there are some hormone-responsive tissues in the body na kapag meron kang hormonal stimulation, for example, estrogen, now your endometrial glands will proliferate, no? Or compensatory response to decreased cell mass in the case of liver resection, no? So, example of which is your endometrial hyperplasia without atypia. So, if you have estrogen excess, then it will cause proliferation of your endometrial glands, okay? For atrophy naman, it's decrease, no, in cell size and number, and there are many causes of your atrophy, no, including not using the structure, no. So if you don't use it, then lumiliit siya. Or denervation atrophy sa skeletal muscles, no, pag nawalan ka ng innervation. Ischemia, malnutrition, loss of endocrine stimulation. There are some hormones na nagsistimulate ng growth ng something. So, pag nawala yun, mag-atrophy yung tissue. And then pressure, no? When you exert pressure on something, then in time, liliit yan. Okay? So, kung yung hypertrophy ay increase in protein synthesis, ito naman, puro decrease in protein synthesis. There's a net decrease in your protein content in your cells. And an example here is your Alzheimer's disease. As you can see, yung frontal, yung temporal, and yung parietal lobes niya ay may atrophy, no? Yung likod, wala. Medyo normal yung likod. Pero this one, you see that you have narrow gyri and widened sulci, indicative of your brain atrophy. Okay? And then last cellular adaptation is your metaplasia. It's a process where a differentiated cell type is replaced by another differentiated cell type. And it does so because yung metaplastic epithelium can withstand better the stress applied, no, doon sa area. Okay? So, an example here is your Barrett esophagus, no? So, yung sa left side natin, yan yung squamous epithelium ng esophagus, and then yung right side, ito yung gastric epithelium. Supposedly, wala yung goblet cells because goblet cells are only seen in the intestine, no? But here, nakikita natin, meron tayong goblet cells dito sa tiyan. So, alam nating metaplastic epithelium yan. Okay? Now, let's go to cell death. So, pag cell death, kapag severe naman masyado yung insult, ang nangyayari, cell death na, no? And we have two main forms of your cell death, your necrosis and your apoptosis. So first off, we have our necrosis, no? It's a consequence of severe cell injury. So because of that, namamatay yung cell in the form of necrosis. Okay, so ang tatandaan nyo, dalawang features sa necrosis. Kulay pink siya at wala siyang nucleus. Yun. So, it's eosinophilic and anucleate. Okay, so the nuclear changes are as follows. So, karyolysis, the nuclei dissolves, no? Your pycnosis, the nuclei shrinks into one compact dot, and then karyorrhexis, the nucleus fragments. Okay, so ang whatever process there is, no, ang nangyayari diyan, madi-dissolve eventually yung nucleus, and you will end up with an anucleate necrotic cell. So pink and then anucleate. Now, what are the patterns of necrosis? We have 6 main patterns, no? Coagulative necrosis is seen in ischemia, no, of solid organs, no, except your brain. Okay, i-discuss natin mamaya kung ano yung necrosis as ischemic lesions of the brain, no. As you can see here in our example, we have here a case of MI, no? Mukha pa rin siyang cardiac muscle cell, but then very pink and walang nucleus. So, bakit nare-retain niya yung kanyang architecture? It's because in coagulative necrosis, the denaturation of proteins is slow. That's why nakikita mo pa yung architecture ng tissue or ng cell, no, kapag tinitignan mo siya under the microscope. Now, ito yung mga infarcts, no? Yun. Okay? Now, liquefactive necrosis. Yung liquefactive necrosis, ang tatandaan nyo dito, may nana sila, no? So, pus, suppurative, purulent, liquefactive necrosis yung mga yon, no? Now, it happens most of the time with in bacterial and fungal infections and in ischemic lesions of the brain, no? So, ang nangyayari dito, marami kang acute inflammatory cells and they're capable of destroying the tissue. So, ang nangyayari, kung marami kang neutrophil, maraming tissue destruction, so you will end up with a pus, no, which is composed of your leukocytes, your necrotic debris, and fluid, like this. Now, gangrenous necrosis usually a term applied to a loss of blood supply of the limb or a limb ischemia. And the morphology is the same as coagulative necrosis, but it involves multiple tissue planes in the case of dry gangrene. Now, pwedeng may superimposed liquefactive necrosis yan or wet gangrene if you have superimposed infection. Now, caseous necrosis naman or caseous necrosis, so you see them usually in tuberculous infections, no, and it's a cell-mediated immune response, no. Malalaman nyo yan sa chapter 5 and sa chapter 2. Okay? So, yung caseous necrosis, para siyang cheese, kaya siya tinawag na caseous, so parang yellowish white siya, no, na area of necrosis. And here is a tuberculous granuloma showing the central caseation necrosis. So, yung parts ng granuloma, i-delay na lang natin siya sa next chapter. Okay? Next is your enzymatic fat necrosis. So, it's usually seen in your acute panc and your breast fat necrosis. And it happens when the blood or pancreatic lipases come in contact with your fat cells. Okay? So, they will destroy your fat cells and then magkakaroon ka ng saponification. So, grossly, meron kang chalky white areas, no, of your saponification, and microscopically, makikita nyo here, no, itong mga nasa asterisk na to, mga patay to na fat cells, no, and the fat will be released, no, to the environment, kaya napapalibutan sila ng maraming macrophages na punong-puno ng fat. Okay? And then last is your fibrinoid necrosis. So fibrin, 'di ba? Pag sinabing fibrin, usually alam mong it has something to do with blood. And therefore, malamang-lamang yung may problema ay yung blood vessels, no? So you see fibrinoid necrosis in your immune-mediated vasculitis. Here we have an example, no, of an inflamed vessel in your polyarteritis nodosa, a type of vasculitis. As you can see, meron kang parang mesh-like na pink material, and that is your fibrinoid, and it is accompanied by your inflammatory cells. Dito marami kang makikitang neutrophil. So, the pink material is because of your immune complexes, no? Okay? Immune complex deposition. So the next major form of your cell death is your apoptosis. So it's programmed cell death. So these are the morphologic changes. Maliit yung cell because yung chip off, no? Parang nagbabud off kasi yung cytoplasmic contents niya as apoptotic bodies, kaya siya lumiliit. And the most characteristic feature is your chromatin condensation. Now, you have macrophages because the apoptotic bodies are being engulfed by macrophages, and characteristically your apoptosis does not have any inflammation, and that is in stark contrast to your necrosis, wherein there is almost always inflammation. Now, why is that so? It's because there's no release of cytosolic contents that can trigger inflammation. In your next chapter, your inflammation and repair, malalaman nyo na yung cytosolic contents, marker siya ng cellular damage and therefore can trigger inflammation. So, wala kasing ganon, no, in your apoptosis dahil walang natatapon, walang inflammation. Okay? And the macrophages in your apoptosis, they have different, they are wired differently, no? Instead of producing inflammatory cytokines, they inhibit, no, the production of pro-inflammatory cytokines. So here's an example. We have here the starry sky pattern of your Burkitt lymphoma, and the sky is the tumor cells, no? The sky is composed of your tumor cells, while the stars are composed of your macrophages that are phagocytizing, no, your apoptotic bodies pointed by the arrow. Okay? So here's a table, no, showing yung key differences ng necrosis and your apoptosis. High-yield table yan, so make sure that you know this by heart. Okay. Now, what is your autophagy? So your autophagy is a process where the cell eats its own contents, no? And it does so because it needs to survive, no, in times of nutrient deprivation, or if something develops within the cell that is undesirable, no, pwede siyang i-degrade. Okay? Now, some diseases, no, are the pathophysiologic basis of some diseases is impaired autophagic response, nor autophagic pathways. For example, your neurodegenerative diseases or like your Alzheimer's disease. So, ang nangyayari kasi, there is an abnormal protein accumulating in the neurons, no, in your Alzheimer's disease, and hindi siya kayang tanggalin ng body, no? And these abnormal proteins, they trigger inflammation and they trigger the unfolded protein response, which ultimately lead to neuronal injury and death. Kaya ka nagkakaroon ng neurodegeneration. So more of that in your second to the last chapter, your chapter 27. Now, in intracellular accumulations, isa lang yung i-discuss ko, the hyaline change. Lagi nyo kasing maririnig yung hyaline across, no? So, pag sinabing hyaline, it's a pink material. No, it's a pink homogeneous glassy material, no, in your H&E. And then, it can be highlighted by your periodic acid shift or your PAS. Now, in terms of glycogen, no, glycogen and a lot of other things can appear hyaline or hyaline in your H&E. But how do you distinguish a glycogen hyaline from the rest? No, you do your diastase treatment. So your diastase will destroy, no, your glycogen, and therefore, no, magne-negative siya with your diastase treatment. As you can see here, sa right pane, no, pink siya. Very pink. So, andyan yung glycogen, no? But then, pagka tinreat mo na siya ng diastase, mawawala na siya. So, alam mo na yung hyaline na yon is glycogen. Now, it's a non-glycogen if nagstay pa rin siya after diastase treatment. Now, in terms of pathologic classification, dalawang i-discuss natin, dystrophic and metastatic. First off is dystrophic. Dystrophic, D is for dead, no? So, it's a calcification that occurs in dead tissue, no? In dead tissue. And if it occurs in dead tissues, you don't need high calcium levels. So it happens even in the setting of normal calcium levels. So an example of which is a Samoma body. Here we have a serous carcinoma of the uterus, and it's arranged or it's disposed in papillary fronts. Now, those papilla can break off and die no, and become papillae can break off and die and become a psammoma body. Okay? And then for metastatic calcification naman, it happens in living, no? It happens in living tissues. M is for mabuhay. So it happens in living tissues, and because it happens in living tissues, you need high calcium levels, okay? So here is an example of calciphylaxis. So nakikita nyo yung purple na material na yan, no, within your blood vessel. So that is your calcification, okay? So sunod natin yung inflammation and repair, okay? So, inflammation, TLDR, TLDR yung definition. But, when you encounter the words with itis na suffix, it means that that is an inflammatory process. Now, hindi lang infection ang cause ng inflammation, no? Pwede ring immune reactions, tissue necrosis, as you have learned, no, in your chapter 1, and presence of foreign bodies. Now, there are 5 cardinal signs of your inflammation. So, rubor and calor, redness and warmth, are caused by increased blood flow because of vasodilation. Now, dolor, it's because the inflammatory environment, no, is rich in your pain substances. Now, tumor happens because of increased vascular permeability, which leads to edema. And then your functionalisa, in your inflammation, there is some degree of tissue damage, and that will translate to decrease or loss of tissue function. Okay? So there are 5 general steps of inflammation, no? And these are your 5 R's. So the first one is recognition of your injurious agent. So our immune system will recognize the presence of an offending agent or indicator nun, which is yung cell damage. Ito yung sinasabi ko sa inyo kanina, no? That your intracellular contents, they're markers of cell damage and therefore can trigger inflammation, no? So basically, ito yung mga examples, no? Ang ending niyan, it will trigger the inflammasome to produce your IL-1, no, your interleukin-1, and then it starts there, no? It will trigger your inflammation. Now, next is recruitment of your leukocytes. Now, ang inflamed tissue, pathologically, madami siyang inflammatory cells. So, bakit ba madaming inflammatory cells ang isang inflamed tissue? It's because there is leukocyte recruitment. So, there are 5 steps in your leukocyte recruitment. Margination, because of the vasodilation that happens in your inflammatory process, your white blood cells, they assume a more peripheral position in the blood flow, no? So they come in contact with your endothelium, and then it interacts, no? Your leukocyte interacts with your endothelium, no? Yung rolling and adhesion yon. So rolling is transient and weak. It's mediated by selectins, while adhesion is firm and permanent, no? Adhesion to the endothelium, and that is mediated by your integrins. So later, magsi-squeeze out, no, yung iyong inflammatory cell across the vascular wall, and then it will free itself, no, from the vascular wall, and that is your diapedesis mediated by your CD31 and PCAM1. And then, paano siya pupunta dun sa inflamed tissue? The inflamed environment is rich in your chemoattractant molecules, no? So, nare-recognize yon ng mga inflammatory cells, and dun sila nagmo-move towards, no? And there are many, no, chemotactic signals, no? Your bacterial N-formyl methionine, no, is one of them. And then for exogenous, you have your pro-inflammatory cytokines, products of complement, no, and some leukotrienes. Okay? So, pag mataas ang concentration ng mga chemotactic signals na yun doon, doon tayo kasi inflamed doon. Okay? Yun yung mindset. Yun yung mindset ng white blood cells. So, there are different types of leukocytes for different types of inflammation. So, for acute inflammation, usually neutrophils yung nandyan. And they're the acute ones kasi short yung lifespan nila. So, habang may inflammatory stimulus doon, andun yung neutrophils. But they're short-lived, no? They usually die after 24 to 48 hours and replaced by your monocytes. Kaya nakikita mo yung monocytes in those more than 48 hours, no? Or 72 hours. Basta day 3, no? Usually, yung monocytes nandyan na. Now, for viral, lymphocytes, for allergic, eosinophils, alam nyo naman yun, no? Now, the next R is removal of the agent. Now, the leukocytes, they have mechanisms, no, like your ROS, your respiratory burst, diba, your lysosomal enzymes, no, and sometimes they can extrude their contents, no, as neutrophil extracellular traps, no, and those contain antimicrobial substances. So basically, they're armed, no, with mechanisms to kill the offending agent. And that is the physiologic consequence of your inflammation. Now, syempre, hindi naman yun nangyayari in a vacuum. It happens with the surrounding tissues there, no? So, yung surrounding tissues na yun, nadadamage din siya, and that is the pathologic consequence of your inflammation. Okay? Now, inflammation should be, and normally is, a tightly regulated response. So, paano yon, no? Yung inflammatory mediators natin, they have short half-lives. Pag di na sila kailangan, mawawala na sila para mawala din yung inflammation. Yung neutrophils also have short half-lives. And the body produces anti-inflammatory cytokines when needed, including your lipoxin, TGF-beta, and your IL-10. Tandaan nyo yung 10 kasi siya lang naman yung inflammatory cytokine na interleukin, no? The rest are usually pro, no? Okay, so speaking of that, no, we will talk about inflammatory mediators. Okay, so your inflammatory mediators, these are substances that modulate your immune responses. They can be synthesized by cells or by liver, no, or by the liver, and then dinadump niya sa blood. Okay, so these are just produced on demand, no, yung mga ibang mediators. Okay? And most mediators are short-lived in keeping with the tightly regulated nature of your inflammation. Okay, so let's start with your vasoactive amines, so histamine and serotonin. So para matandaan nyo siya, okay, alin dyan ang constrictor, yung may O, no? Yung may O, vasoconstrict, no? So siya yung may constrict. So siya yung may O, serotonin. Yung histamine, walang O. So siya yung dilate. Okay? So, histamine comes from your histidine, and it's produced by your mast cells, platelets, and your basophils. Again, it's a vasodilator. No, it increases your vascular permeability. Yung serotonin naman, it's from tryptophan. It can be synthesized by your platelets and neuroendocrine cells, and it's a constrictor. So again, kung ano may O, yun ang constrictor. Now, arachidonic acid metabolite. So your arachidonic acid is an omega-6 fatty acid, and that explains why your omega-6 fatty acid containing foods are pro-inflammatory. So there are two pathways, no? Your cyclooxygenase and your lipooxygenase. Your cyclooxygenase produces your prostaglandins and prostacyclins and your thromboxanes, while your lipooxygenase, it produces your leukotrienes and your lipoxins. No, so alin ang dilator? The prostacyclins and the prostaglandins, while your constrictors are the thromboxanes and your leukotrienes. Some of them, your leukotrienes can increase vascular permeability, and some of them are chemoattractants, no, like your leukotriene B4. Okay, so now let's go to your cytokines. So your cytokines, they're the ones regulating your immune and inflammatory reactions, while your chemokines are chemoattractant molecules. Okay? So, ang dami, no? So, these are, I offer you a memory device. So, yung holy trinity of cytokines, the IL-1, IL-6, and your TNF, you should remember them kasi lagi sila magkakasama for some reason because they have systemic effects. No? And then single IL-1 is the single root cause of all evil. As we have learned in the previous slide, yung recognition, it starts with your IL-1 and then it will trigger inflammation, no? Doon na magsa-start yun. And then yung IL-2, T cells for TT, and then your IL-3 is for your trilineage hematopoiesis, no? And then yung IL-6, six-pack, maraming protein, so that is increase in your acute phase proteins, and your IL-8 is your chemokine, no? It's a neutrophil chemoattractant. Now, actually, itong mga to, ma-encounter nyo naman yan sila as you go along, no, the rest of the material. So, ito lang naman yung sa tingin ko mga kailangan nyo talagang tandaan. Okay? So, complement. Ang complement, these are proteins, no? They're synthesized in the liver and then they're found in your blood, no? So, itong complement, no, it's a set of proteins, madami siya, and then meron kang cascade na nangyayari kapag meron kang trigger, no? And itong mga pathways na to, meron kang 3 pathways of your complement initiation or complement activation. So the first one is your classical. So your classical, as you can see here in the photo, it's triggered by your immune complexes, no? Particularly yung antibody, no? It's activated by your antibodies. And then, yung alternative pathway naman ang nangyayari, it's activated by your microbial products. And your lectin closely resembles your classical pathway, but your C1 is substituted with your mannose binding lectin. So for classical pathway, ang nangyayari once nag-bind yung C1, no, and your antibody, once nag-bind yung antibody dun sa microbe, so yun na yung immune complex mo, the C1 recognizes it, no? And then the C1 will cause, no, activation of your C4 and your C2. These are your early complement components to make your C3 convertase in order to cleave your C3. And that's the common that's the common pathway, no, the cleavage of your C3. In your alternative pathway naman, ang nangyayari is yung C3 mismo, no, it becomes C3b, and C3b is an opsonine, as you will learn later on, and it will bind to the microbial surface. Okay? So, from then, eventually magkakaroon ka din ng C3 convertase to promote further cleavage of your C3. And then your lectin pathway naman, parang classical, but again, mannose binding lectin ang nagbabind sa mannose residues ng microbe. It's because your mannose binding lectin is functionally like your C1. So, the complement process summary is as follows. No? So, may initiation pathway ka which depends on the trigger, no? And then, ang common pathway is the cleavage of C3. Then, the cleavage of C5 will happen, and then the formation of your membrane attack complex. So, your C1, it activates your classical pathway, while your C4 and C2 are your early complement components together with your C1. No? So, yan yung nagpa-participate in the formation of your C3 convertase to cleave your C3. Now, C3 is the most abundant complement, and when it is cleaved by your C3 convertase, it becomes C3A, which is an anaphylatoxin, and your C3B, which is an opsonine. No, now, eventually, down the line, you will also have a C5 convertase that will cleave your C5, which also gives rise to an anaphylatoxin, your C5A, and C5B, which is part of the membrane attack complex. Now, the later steps of your complement activation center on the formation of your membrane attack complex, which consists of your C5b and your C6 to C9, the late complements, the late components of the complement system. Now, ano ba ang nagiging product ng complement activation? Inflammation, no? Opsonization and cell lysis. For inflammation, the anaphylatoxins, your C3A, C4A, and C5A, kaya sila tinawag na anaphylatoxins because parang anaphylaxis yung dating ng reaction nila. No, because it promotes histamine release from your mast cells. Kaya siya anaphylatoxin. And then, one of them, no, your C5A is capable of leukocyte recruitment, kaya ka nagkakaroon ng inflammation. Now, opsonization, nabanggit ko kanina sa C3b. So, your C3b acts as an opsonine, so it coats target cells in order for them to be more palatable to your phagocytes. And then, yung cell lysis, C5b, C6 to C9, it's due to your membrane attack complex. So, these are your complement-related diseases. Your C2, it's the most common complement deficiency. And your C3, when you have C3 deficiency, of course, wala kang complement response, no? Inadequate yun. And therefore, you're susceptible to pyogenic infections. And in immune complex-mediated glomerulonephritis, you will later learn that C3 is consumed kasi ginagamit siya for formation of your immune complexes, kaya bumababa ang C3 levels in your glomerulonephritidis. And then hereditary angioedema for your C1 inhibitor deficiency, PNH for your DAF and your CD59 deficiency, and then late component deficiency for Neisseria, and then the rest. Okay? So, ma-encounter nyo naman yung iba dyan, most of them, no, as we go along the material. And then, These are some other mediators. So yung platelet activating factor, you will later learn in your chapter 9 that it's implicated in a condition called necrotizing enterocolitis, no? Because it also increases mucosal permeability. Now, what's notable about this is that depending on the concentration, nag-iiba yung ka-action niya. Pag low, dilate. Pag high, constrict. Okay? Ng vessels. Bradykinin, para siyang histamine din yung yung kanyang action. No, you have increased vascular permeability, dilation, and smooth muscle contraction. Okay? And then substance P is for pain. Now, on a pathologic standpoint, no, what are the types of inflammation? Two major is your acute and chronic. On a pathologic standpoint, it differs based on your inflammatory infiltrate. So, pag acute, alam nyo na, neutrophils, di ba? And in most cases of acute na self-limiting, no, the tissue injury is usually mild, no, and fibrosis is minimal or even absent, no. While in your chronic, no, because there is long-standing insult, usually the tissue injury is severe and progressive, and there is fibrosis, no, in your chronic. Remember that your chronic inflammation is married to your fibrosis. Pag may chronic inflammation, lagi yung sinusundan ng fibrosis. Okay? And the inflammatory infiltrates are composed of your mononuclear cells, your monos, your macrophages, and your lymphocytes. Kasi nga, di ba, ang neutrophils, as you have learned previously, namamatay sila agad. Okay. Now, let's go to acute inflammation. So, these are the components of your acute inflammation. You have vasodilation, you have increased vascular permeability, and you have leukocytic infiltration. Okay? So, in dilation of small blood vessels, alam nyo naman, may mga vasoactive amines na napoproduce, no? And that can cause your vasodilation. Now, that will cause increase in the flow of blood, and that explains the rubor. And because of the vasodilation, there is slowed blood flow, which initiates your margination of the leukocytes. Okay? So, ito yung picture na perfect example ng acute inflammation. So, you have dilation of your blood vessels, and then you have edema, which appears here as increased clear spaces kasi may tubig, and then you have a lot of neutrophils around. No? So, yung increased microvascular permeability, ano ba yon? No, that is the one that causes your edema. So, paano nangyayari yon? Now, the most common mechanism is endothelial cell contraction. Now, meron tayong mga inflammatory mediators that can cause this, like your histamine, for example, bradykinin. And because of the endothelial cell contraction, ang nangyayari, nagkakaroon ka ng gap. Tapos, from those gaps, doon nagkakaroon ng seepage ng fluid, no? Kaya ka nagkakaroon ng edema. Now, the next one is your endothelial injury. Ito yung major. Ito yung dalawang major yung endothelial cell contraction and your endothelial injury. So, pag endothelial injury naman, pag dinestroy mo yung endothelium, well, magiging magiging very leaky yung vessel mo. And that can cause a prolonged and severe increase in microvascular permeability. Okay? Now, lymphatic vessels, dahil maraming edema fluid, to maintain a bit of a semblance of equilibrium or homeostasis, your lymphatic vessels compensate and proliferate, in order to handle the excess edema fluid. Now, sometimes they can be inflamed, yung lymphatic vessels mo, you call that lymphangitis, and sometimes the inflammation or the infection can spread, to your lymph nodes kung saan sila nagde-drain, and nagkakaroon ka ng lymphadenitis. Okay? Now, what are the morphologic patterns of acute inflammation? We have 4, but regardless, kung ano yung components ng acute inflammation, yun din yung hallmarks na nakikita nyo sa kanya. Okay, now we have 4. First with cirrhosis. So, cirrhosis, ito yung mga matubig na acute inflammation. Okay? So, they're seen in viral infections, and particularly, yung mga vesicle forming, like your varicella, for example, So, ito, makikita nyo here, marami kang clear space, ito yung tubig, And then you see a lot of cells with intranuclear inclusions, and those are in keeping with viral cytopathic effect. You also see accompanying inflammatory cells, pero di siya ganong ka-dense, Now, for your fibrinous naman, you have, with your inflammatory cells, fibrin. Okay? You have fibrin strands here. So, this is an example of your bronchopneumonia. As you can see, marami kang inflammatory cells, but meron ka ding mga fibrin mesh work. Okay? And then yung purulent, ito yung madaming neutrophils, no? So this, ito yung mga may nana. Okay, so this is an example of acute pyogenic meningitis. So on the left yung brain, and then right yung meninges, and then sa gitna niya yun sa arachnoid space mo, makikita mo sobrang daming neutrophil, no? So grossly makikita mo yan, kulay dilaw, no? Manana, yan. Okay? Or ulcer. Yung ulcer, sundan nyo yung epithelium ng tiyan, and then bigla siya magkakaroon ng excavation, no, with denudation of your epithelium, no, your gastric epithelium. So this is your gastric ulcer. Now, if the ulceration will involve a vessel, then it can be a source of bleeding, which is in this case, no, it's a bleeding peptic ulcer. Okay? So what are the outcomes of your acute inflammation? You have your resolution, no? So pwedeng pag nawala na yung stimulus, then mawawala na siya. Or pwedeng kapag, no, severe yung inflammation, kapag kaya niyang yung offending agent can trigger an intense, no, a very intense acute inflammation, you can have abscess formation. Or if the offending agent is not eliminated, then it can progress to chronic inflammation. And in these two cases, your abscess formation and your progression to chronic inflammation, it will ultimately heal by fibrosis. Now, bakit fibrosis din yung abscess formation? 'Di ba? Sabi ko kanina, usually mild lang naman, no? Yung tissue injury and wala halos fibrosis. Now, your abscess formation, it's severe, no? Severe acute inflammation, and therefore there is tissue damage. The stem cells are also compromised, no? And when you have that kind of severe inflammation, there's a lot of fibrin around, no, which can trigger fibrosis, no? Kaya yung abscess formation nag-heal din siya by fibrosis. Okay? So, chronic inflammation. Okay? Pag sinabing chronic inflammation, it's prolonged. And therefore, when it's prolonged, it's not just the inflammation that you see, no? It's also evidence or attempts at tissue repair, no? And the causes, if you look at the causes, usually they're chronic causes, no? So, you have persistent infection, no? You have prolonged exposure to toxic agents, and then hypersensitivity diseases or your autoimmune diseases, and these are also chronic diseases, no? So, anong meron sa kanya? Again, mononuclear infiltrates kasi nga pag chronic, usually wala ng neutrophil unless there is a superimposed acute inflammation. And then, because of the long-standing injury or long-standing inflammation, you expect some degree of tissue destruction and you expect fibrosis, no? Here we have your chronic inflammation of your kidney. As you can see, may dalawang glomeruli dyan. And then, sobrang intense nung fibrosis mo. And then, marami kang mononuclear cells na naka-infiltrate around. Now, what are the key players in your chronic inflammation? The macrophages and your lymphocytes. So, actually, kung mag-single out ka, it's the macrophages, no? Yung pinakabida sa chronic inflammation. They're very versatile, no? They're very versatile cells. They're phagocytic cells. And because they're phagocytic cells, they can process your antigens and present it to your immune effector cells, no? So, they're also capable of antigen presentation, and they're, depending on the method of activation, they're capable of promoting inflammation and even withdrawing it or inhibiting it and promoting repair. Okay? Now, your lymphocytes naman, especially the CD4 T cells, because of the cytokines that the CD4 T cells will produce, no, they promote or they will promote inflammation. And then your B cells, they can differentiate into plasma cells and produce your antibodies. Now, pwede kang magkaroon ng mga eosinophils, neutrophils, again, in your chronic inflammation, provided that there is a superimposed acute inflammation. Now, chronic inflammation, a special type of this is your granulomatous inflammation. Okay, so these are lesions that you classically see in your tuberculosis, no, and it's a product of a CD4 T cell response. So you need your intact cell mediated immunity to produce these kinds of lesions. Okay, so ano bang nangyayari sa kanya? Due to your CD4 T cell mediated response, no, your helper TH1 response, you activate your macrophages to become epithelioid cells. no, or multinucleated giant cells. So these epithelioid cells and Langhans type giant cells, they're derived no from your macrophages. And then in sa TB kasi usually may central cacheation necrosis yan. Now the whole thing is rimmed by your lymphocytes. So yan yung anatomy no ng iyong tuberculous granuloma. Lahat ba ng granuloma may cacheation? Hindi, no? There are some non-cacheating granulomas caused by different diseases. So, for example, a non-cacheating granuloma can be seen in your Crohn's disease, no? You will learn that later in your GIT. Now, systemic effects of your inflammation. So, ano ba yung nakikita natin sa patients kapag meron tayong inflammatory disorders, no? Kapag meron silang ganon. So, fever, di ba? Unang-una na yon. So, fever, tumataas yung temperature nila. It's because there is production of your pyrogens, no? So, ano ba yung mga pyrogens natin? Yun nga, nasa Holy Trinity of cytokines pa rin, your IL-1, your TNF, no? And your exogenous cytokines, these are exogenous substances, no, like bacterial products, which promote production of your endogenous pyrogens. So basically, yung endogenous pyrogens talaga ang nagwo-work, no? So those endogenous pyrogens increase the production of your prostaglandins that leads to elevation of your temperature set point. Kaya tumataas ang iyong temperature. Now for your acute phase response naman, no? Holy Trinity pa rin ang bida. Ito masabi ko sa'yo, pag systemic effects, bida talaga ang Holy Trinity of cytokines. So your IL-1, your IL-6, and your TNF, they increase plasma proteins that are typically increased in your inflammation, no? And then, ito yung mga acute phase proteins natin, your CRP, no? Ang noteworthy dyan sa CRP, it's a marker of increased risk for MI, no? In patients with coronary artery disease. Okay? And for your fibrinogen, it's increasing your inflammation and that causes rouleau formation which increases your erythrocyte sedimentation rate. Kaya increase ang sed rate at saka CRP in cases of inflammation. And then you have your serum amyloid A, your hepcidin, and your thrombopoietin. No? So basahin nyo na lang yan. And then yung leukocytosis, syempre alam natin yan, no? Kaya tayo nagre-request ng CBC para sa mga infections. Usually mataas yung mga yan, no? And anong reason for that? It's because kapag may inflammation ka, kailangan yung iyong granulocytes. So therefore, they're mobilized in the bone marrow, no? They're mobilized in the bone marrow, and if that's not enough, the bone marrow is stimulated to produce more by the colony stimulating factor. So ano nga yung cytokine doon? It's the IL-3, di ba? Trilineage hematopoiesis. Now, the fifth R is repair, which involves restoration of your tissue architecture and function after an injury. So, we have two general types of repair. Now, your regeneration and your connective tissue deposition, or simply put, fibrosis. No? So, yung regeneration, it happens in your labile and stable tissues. Now, while your connective tissue deposition happens in your chronic inflammation, severe inflammation, and your permanent tissues. Okay? So, ano ba yung mga label na yan? Okay? Now, this is the classification of tissues by regenerative capacity. Pag sinabing label, kaya nila mag-proliferate ng bongga. Okay? So, examples of that are your surface epithelium and your hematopoietic stem cells. So, pag na-injure mo sila, sige, produce pa tayo. Yun na lang. Ganun na lang. Kaya regeneration, usually yung nangyayari sa kanila. Now, stable tissues are generally quiescent, no? But then, kapag merong insult, like tissue injury or loss, pwedeng mag-proliferate yon, no, yung mga stable tissues, but they only have a limited capacity to do so. Once it exceeds its replicative capacity, then usually nag-heal sila by fibrosis na. No, a perfect example of this is your liver. Now, permanent tissues, these are not capable of dividing postnatally, no, and therefore the method of repair na available lang sa kanila ay fibrosis. Example is cardiac and skeletal myocytes, no, and your neurons. Okay? So, what are the important events in your connective tissue deposition? Well, you form your granulation tissue, and this is the scaffolding of your fibrous scar, no? So yung granulation tissue, siya yung hilaw na scar. And anong itsura niya? You have a lot of your vessels, no? You have a lot of vessels, and that is because of your angiogenesis. And then you also have fibroblasts, inflammatory cells in your loose connective tissue. Now, yan yung magiging scaffolding for your fibrous scar. And yung maturation process involves a deposition of your collagen and collagen remodeling until it becomes a mature fibrous scar. Remember that your granulation tissue is not synonymous to your granuloma, because granuloma is an inflammatory lesion while your granulation tissue is a repair lesion. Okay? So what are the factors that impede repair? Remember this, no? Kapag meron kang infection, kapag meron kang persistent infection, hanggat nandyan yan, hindi yan magre-repair, no? If you have immunodeficiency, no? Syempre, hindi mo mafa-fight yung infection. Kaya, magpa-persist yung inflammation, and yung repair mo ay mai-impede. Now, other than that, you also need good wound healing, which is influenced by your perfusion. So if you have poor perfusion, no, if you have vascular insufficiency, then hindi ka mag-heal ng maayos. If you have pressure, which also impedes perfusion, no, magkakaroon ka din ng impaired healing. Now, foreign bodies, of course, dahil yung foreign bodies mahirap yung i-eliminate, there usually is persistence of inflammation. Kaya nag-i-impede yung repair. Okay? And then if you're immunosuppressed, like you're in DM and your steroids, then hindi mo makiklear yung infection, and you will have a slow repair process. Now, in terms of abnormalities in tissue repair, i-discuss lang natin yung keloid and hypertrophic scars. So these are because of your excessive collagen formation. Now, on top is a normotrophic scar. And then, pag sinabing hypertrophic scar, so meron kang excess collagen, but then hindi siya nag-exceed dun sa edges ng wound, no? Hindi siya nag-grow beyond the edges of the original wound. So as you can see, malaki lang siya, pero ganun pa rin yung itsura niya. And then yung keloid scar kasi, mag-expand siya, no? It will grow beyond the confines of your original wound. And that ends your inflammation and repair. Okay, let's now go to your hemodynamic disorders. So, first off, we have edema and effusion. So, pag sinabing edema, it's accumulation of fluid in the tissues. Pero pag effusion, it's in body cavities. Your peritoneum, your pleural cavity, and your pericardial cavity. Now, these are the mechanisms, no, and the respective examples. So, here we have yung Starling forces natin. So, yung ating, we have hydrostatic pressure, no, which is determined by the volume of the fluid that compartment handles. And then, yung oncotic pressure, which is determined by the albumin concentration in that fluid compartment. Okay? So, if you have increased hydrostatic pressure, such as in heart failure, because there is impaired blood flow, no? So, nagko-congest, then that is for your increased hydrostatic pressure. If you have nephrotic syndrome, you have increased renal loss of your albumin, or liver cirrhosis, you have decreased synthesis of your albumin, then that is decreased oncotic pressure. Kaya ka magkaka-edema. Now, if you violate your endothelium, if you injure that, as you have learned in your inflammation and repair, such as burns and infections, you can have increased vascular permeability and edema. And then lymphatic obstruction, because if you obstruct, no, your lymphatics, yun supposedly yung mag-handle ng excess edema fluid. So, pag in-obstruct mo yun, then hindi mo makiklear yung edema fluid. Okay? And then, sodium and water retention. If you have sodium and water retention, you increase your intravascular volume, and therefore, you have increased hydrostatic pressure. And because of the increased fluid, no, increased water, you dilute your albumin concentration, no, kaya bumababa siya. Kaya pwede rin siya for decreased oncotic pressure. So, it works both ways. Okay? And then, what are the types of effusions? You have your transudate and your exudate. So, ang tatandaan nyo lang yung exudate because it involves some degree of injury, no, to the endothelium, because the endothelium is violated or compromised. Usually, mataas lahat ng something niya, no? Mataas vascular permeability, mataas yung proteins, mataas yung specific gravity, may fibrin, may inflammatory cells, no? So, yon. Now, in terms of appearance of effusions, usually your transudates are clear, no? While your exudates can be clear or serous, can be fibrinous or granular kasi may mga fibrin deposits, or pwedeng maging frankly purulent or nana, or pwedeng maging hemorrhagic. Okay? So, ano ba ang edema? Ano ba ang edema microscopically? So, basahin nyo na lang yan, but I will give this example. No? This is a dermal edema. As you can see, yung bottom left niya, compact yung collagen fibers ng dermis. Pero dito, nakikita mo, naghihiwa-hiwalay siya at marami kang clear spaces. And that is your dermal edema. Okay? Now, hyperemia and congestion. So, nakikita nyo naman, bright red si hyperemia, si congestion, medyo purple. So, they are both characterized by increase in blood volume in your tissues, but they differ in some respects. No, your hyperemia is an active process, and it's caused by arteriolar dilation. Therefore, there's increased delivery of oxygen-rich blood, kaya bright red si hyperemia. No, now congestion, ang nangyayari, there's impaired venous outflow, and therefore the deoxygenated venous blood stays within the tissue, which colors it a dusky color, no? So, ang dami. Okay? So, ito yung mnemonics ko, no, for your congestion morphology. No, pag sinabing acute congestion, syempre, if you have congestion, you have increased blood volume, no? So, that's increased hydrostatic pressure and you will have edema. So, you will have edema, and then, pag nag-rupture yung mga vessels na yun, you will have hemorrhage. Now, for chronic congestion, that recent hemorrhage will be phagocytized by your hemosiderin-laden macrophages, and therefore, meron kang yun yung maging marker mo for old hemorrhage. And of course, when you hear the word chronic, there's always fibrosis and severe or organ damage, no? Because yung fibrosis mo, nare-replace niya yung supposedly viable tissue. Okay, now hemostasis. Hemostasis is a process of formation of your blood clots, no? And these are the players, your endothelium, your platelets, and your coagulation factors. So the first step in your hemostasis is the initial vasoconstriction. Siyempre, pag nagkaroon ka ng bleeding, the initial response is to constrict to limit blood loss. So that's a reflex mechanism. And then after that, you will have your primary hemostasis. So P is for primary is for platelets. So platelets ang key players in this phase, and it happens when the platelet interacts with your endothelial with your vascular wall, no? And it will cause your platelet adhesion, no? And then yun yung interaction ng platelet with your vascular wall, and then it will cause a series of changes, no, or reactions, and those are collectively called your platelet activation, until ang ending is yung platelets nyo mag-aggregate and you will form a primary hemostatic plug. Now that is not stable, and that is where your secondary hemostasis comes in. No, ang key player naman dito is your coagulation cascade. So in between those aggregated platelets, no, you will have a fibrin, no, and then magkakaroon ka ng stable fibrin clot. Okay? Now, the clot will eventually stabilize, and then kapag hindi na siya needed, it will be resorbed. No? And that is the fourth phase of your hemostasis. Now, there are inhibitors of coagulation. No? Your protein C, S, antithrombin, and your TFPI. No? Your protein C inhibits your factors 5 and 8. Your protein S is a cofactor of your protein C. Your antithrombin inhibits a lot of things, and your tissue factor inhibits your 7, no? Your tissue factor, and as well as your 10A. Now, we have two fibrinolytic factors here. Your plasmin is the main enzyme for your fibrinolysis. No, it lyses your fibrin clot. Okay? And it is activated by your tissue plasminogen activator, or your TPA. Now, thrombosis is a pathologic counterpart of your hemostasis, and it happens when you have this Virchow triad. No, if you have your endothelial injury, because your normal endothelium is antithrombotic, but then if it's injured, then it becomes prothrombotic. And then your abnormal blood flow, if you have a very turbulent blood flow, it can injure your endothelium. But if you have stasis, it maximizes the platelet contact, no? And retards washout of your activated clotting factors. Therefore, pag nagtagal ang blood doon, eventually magka-clot siya. And then your hypercoagulability, if you have genetic or acquired conditions that promote a thrombosis, no? And consider inherited causes of your hypercoagulability in patients less than 50 years old. So, ito yung mga common, your factor 5 laden. Anong nangyayari? di ba ang protein C, it inactivates your factor 5. In your factor 5 laden, it's resistant to inactivation by protein C, no? And you also have prothrombin mutations. Okay? So, pag mayroon kang endothelial injury and turbulent blood flow, usually arterial thrombosis ang nangyayari. But if you have stasis, usually venous thrombosis ang nangyayari. Now, in your hypercoagulable states, both can happen. So, ano ang itsura ng thrombosis? It's a layer, no? It has a layered appearance of your platelet, fibrin-rich layers, no? Yung fibrin-rich layers nyo na pale, and then meron kang RBC-rich, no, na area. And it's laminated because it means that the thrombus is forming, no, in a flowing blood, which means that it is an antemortem thrombosis. Okay? So those are your lines of Zahn. Okay? Ano bang difference ng arterial and venous thrombosis? Pag arterial, again, nabanggit ko na, di ba? Turbulence or endothelial injury yung cause. Pag venous, usually stasis. Okay? And usually for arterial, it happens in the coronary arteries, cerebral arteries, and your femoral arteries, while your venous thrombosis usually happens in your lower extremity veins. Okay? Now, what are the fates of your thrombosis? It can propagate, no? Pwedeng lumaki. Tapos, pwedeng humaba, no? Yung embolization, pwedeng mag-chip off and then mag-travel to distant sites. Dissolution, pag di na kailangan, mawawala na. Or, organization and recanalization. So, it becomes incorporated in your vessel wall. It can form secondary lumen, no? To restore your blood flow. Now, embolism, no? Yung embolism, di ba nabanggit natin na yung mga thrombus mo, they can chip off, no? And then they can travel to distant sites. So, it's a detached intravascular solid, liquid, or gaseous mass, no? Na carried to a distant site. Okay? So, how does an embolus cause disease? It does so by mechanical obstruction, no? So, pwedeng naka-block siya dun sa vessel, bumara siya dun. Or biochemical injury. Yung laman ng embolus can trigger your coagulation cascade, your inflammatory cascade, no? And can cause vascular injury, diba? Inflammation, organ damage, and your DIC. Okay? So, pulmonary embolism, it's the most common form of thromboembolic disease. So, ang nangyayari dito, if you have thrombus in your if you have deep venous thrombosis, it will embolize to the pulmonary circulation. Okay? So, ang pinakamasamang form ng pulmonary embolism is the saddle embolus, wherein nakalodge siya dun sa bifurcation ng pulmonary artery, no? Pagka ganon, di walang flow talaga, no? Wala talagang flow sa lungs, and then magkakaroon ka ng acute right-sided heart failure, no? And wala kang perfusion, so walang oxygenation. So basically mamamatay ka, no? Pagka meron kang saddle embolus. And then for systemic thromboembolism naman, usually comes from the heart, no? Papuntang systemic circulation. Okay? And of course, if you have blockage, no, ng mga arteries mo, then yung clinical manifestation niya, ischemia. Now, fat embolism, ang titignan nyo dito, may history ng long bone fracture. Tapos, anong mangyayari sa kanya? Usually, meron silang history ng long bone fracture, and then bigla na lang silang magtotoxic, no? You will have pulmonary insufficiency, thrombocytopenia, neurologic manifestations, and then mamatay sila. Now, pag inautopsy mo sila, you will see this fat and marrow within your pulmonary vasculature, no? Now, for amniotic fluid embolism, madali lang naman yung history niya, usually postpartum, and nagtotoxic siya. No, usually, postpartum, tas nag-toxic, postpartum hemorrhage, ganyan-ganyan, pero wala namang atony and all that jazz, no? Okay? So, this is because of biochemical injury, no? Not more so na mechanical obstruction. It's more because of biochemical injury. Now, the contents of your amniotic fluid can lodge into your pulmonary vasculature, no, through a tear in your uterine veins, no? And that can activate your inflammatory cascades, your coagulation cascades, and cause a lot of bad things, no? So, yan yung mga makikita mo, fetal skin, lanugo, hair, vernix caseosa, and your mucin in your maternal pulmonary vasculature. Okay? So, air embolism naman, you need 100 cc to produce symptoms. So, let's just talk about your decompression sickness. So, it happens in your divers. Kasi di ba syempre, kapag nag-deep sea diving ka, there is increased pressure and the gases tend to dissolve. No? Now, if you have rapid ascent, now there is rapid decrease in your pressure. Now, the dissolved gases will assume a gas form again. Now, if you do that rapidly, then they will form air bubbles, no, in your vasculature. Kaya ka nagkakaroon ng mga symptoms. Okay? And then infarction, we have white and red. No, alam nyo naman na yung infarct, it's an area of your coagulative necrosis. It happens in your ischemia. So yung white infarct, it happens in your solid organs or organs with end arterial circulation like your heart, spleen, and your kidney. While your red infarct, they happen in venous occlusion. It happens in venous occlusion. Okay? Kasi pag may venous occlusion ka, there's impaired outflow of your blood. So basically, magko-congest yan, and then mag-rupture yung mga vessels na yun, and then you will have hemorrhage. Now also, loose spongy tissues like your lung, dual blood supply, organs like your lung and bowel, no, congested, di ba? Or reperfusion. Kaya meron kang superimposed hemorrhage in your infarct. So this is an example of a hemorrhagic infarction, a red infarction in your testicular torsion. Ang nangyayari kasi, nagtitwist yung spermatic cord, therefore there is decreased venous outflow, and ang nangyayari, nagkakaroon ka ng hemorrhagic infarction. Okay? Now, ito naman yung white infarct, no? So this is a renal infarct, no? So, yung right side, yung medyo dark staining, yun yung medyo viable. And then, yung left side, ito, this is necrotic. Okay? So, ano bang nakikita nyo sa infarction? Ischemic coagulative necrosis, di ba? And then, for CNS ischemia, nabanggit natin na liquefactive necrosis siya. Now, shock. Okay? Now, shock is when you have decreased blood no, in your body, no? Parang ganon, no? You have reduced effective circulating blood volume, you have diminished cardiac output. Well, basically, the thing with shock is it impairs perfusion of your tissues and leads to organ damage. Okay? Now, what are the types of shock? Your cardiogenic shock. If your heart fails to pump out blood effectively, no? Or there is extrinsic compression or obstruction to outflow, such as in obstructive shock, no? Like in your tension pneumothorax. Okay? Pag di-disturb mo yung normal flow ng blood at hindi nakakapump ng maayos yung heart, then cardiogenic shock yon. And these are the following examples. For hypovolemic shock naman, if you don't have enough volume, then you will have shock, di ba? And then for shock associated with systemic inflammation, you know that your cytokines, no, they can cause increased vascular permeability, no, they can cause vasodilation, and those in combination, no, can cause your shock. Kasi magiging leaky lang yung capillaries mo and mag-aano lang yung fluid, no. Okay, and these are the other causes of your shock. Your neurogenic, no, if you lost your sympathetic vascular tone, no, when you have spinal cord injuries, your anaphylactic, no, which we will discuss in your chapter 5, it's IgE-mediated hypersensitivity. Now, obstructive shock, we have already discussed, no, in your cardiogenic shock. Now, septic shock, ang nangyayari dyan, no, if you have an overwhelming infection, there's a lot of cytokines, no, and these cytokines will promote the following 3 key changes. Hypotension. Now, yung hypotension, it's a combination of your endothelial injury, no, which can cause vascular leakage, no, and edema, and vasodilation. So those in combination can cause low blood pressure. Now, also, if you injure your endothelium, you have a lot of pro-inflammatory cytokines, then you will have disseminated intravascular coagulation because, again, an injured endothelium is prothrombotic, and also, when you have widespread thrombosis, you have subsequent consumption of your coagulation factors, and therefore you will have bleeding naman, no? Yun yung DIC. And then also your inflammatory mediators, they can cause metabolic abnormalities like your insulin resistance and your hyperglycemia, because in terms of stress, 'di ba, your counter-regulatory hormones, no, yun yung nananaig, no, in the body, the steroids, the glucagon, no, yun. Kaya ka merong insulin resistance. Okay, now what are the stages of your shock? So, first is non-progressive, the initial non-progressive stage. So, may kaya pang makompensate, kaya okay pa siya, no? Kaya pa siyang makompensate. Pag yung progressive naman, there's tissue hypoperfusion, there's already onset of your lactic acidosis. Okay, and then yung irreversible, kahit anong resuscitation mo, mahirap na siyang habulin, no? Kasi there's already severe tissue injury. Okay? So, ang morphology ng shock is of course mostly ischemic changes, no? Okay? So, that's your hemodynamic disorders. Let's now go to genetic disorders. So, yung Mendelian disorders natin, meron tayong 4 basic patterns of inheritance. So, first off, we have your autosomal dominant disorder. So, pag autosomal dominant, isa lang ang kailangan mong dominant allele para mag-express ng trait. Okay? So, usually, at least one parent is affected, no? Kasi kailangan mo yung source ng dominant allele. Okay? But in some cases, wala. Normal yung parents mo kasi ikaw ang sinumpa. Charot, no? So, sa'yo nang galing yung, sa generation mo nagsimula yung mutation. Now, with autosomal dominant disorders, there's variable expression. So, there's such a term as penetrance and expressivity. So, yung penetrance, proportion of those who inherit the gene and express its phenotype. So, here in the first row, you have 9 individuals who inherited the gene, but only 5 of them, no, expressed the purple color. Okay, so 5/9 yung penetrance. And then expressivity, kung lahat ng tong 9 na to sa second row naka-inherit ng purple gene, iba-iba sila ng intensity ng purple, no? So, yon. Now, kung manghuhula kayo, kung ang mutation involves key structural proteins or receptors, then malamang-lamang autosomal dominant yan. Now, let's discuss some important autosomal dominant disorders. We have our Marfan syndrome. So, ang defect dyan ay fibrillin 1 gene. At ang target niya ay bone, no, or skeletal system, and then eyes, and then heart. So, sa bones, ito yung kanyang mga manifestations, and it's the most striking feature. So, ito yung mga matatangkad, ganyan, no? Mahahaba ang galamay, no? Yeah. Sa eyes, meron tayong outward and upward bilateral lens subluxation. At yung opposite niya, yung inward-downward, sa homocystinuria mo nakikita. And then remember, in Marfan, the most life-threatening feature is your cardiovascular system. Etong mga to, mahina ang connective tissues nito, kaya prone sila na mag-develop ng mga aortic aneurysm, aortic dissection. Next off yung Ehlers-Danlos syndrome. So kung sa Marfan ang defect ay fibrillin 1 gene, sa Ehlers-Danlos syndrome ang defect ay fibrillar collagen. So collagen. Now, meron siyang autosomal dominant, meron siyang autosomal recessive forms. No, your autosomal dominant, kung papansinin niyo, puro structural collagen genes yung defect. Pero yung autosomal recessive, puro enzymes, di ba? And these are enzymes involved in your collagen synthesis. Okay, so there are a lot of types of your Ehlers-Danlos. So, sauluhin nyo yan, no? And I would like to emphasize yung vascular EDS because it's a risk factor for developing also yung mga aortic aneurysms and dissections. Okay? Kasi, yan o, pwedeng magkaroon ka ng arterial rupture kasi mahina din yung kanilang connective tissue because of the collagen defect. Now, for autosomal recessive disorders naman, kung sa autosomal dominant, isang dominant lang ang kailangan mo. Sa autosomal recessive, 2 recessive ang kailangan mo. Now, recessive alleles, usually, kapag meron yung katandem na dominant allele, nakatago yan. Okay? So, usually, the parents are phenotypically normal. And then, kung parehong carrier yung parents mo, you have a 25% chance of having the trait. Now, pag meron kang 2 copy ng recessive allele, uniform ang expression yan, you will express the full phenotype, no? In contrast with autosomal dominant disorders na may variable penetrance and expressivity, no? Now, pag manghuhula ka kung mga metabolic disorders yan, no, may enzyme deficiency, usually yan ay autosomal recessive. So, let's discuss some important autosomal recessive disorders. We have our Tay-Sachs disease. So, ang defect doon is the alpha subunit of your hexosaminidase A. Pag wala yon, mag-accumulate yung ating GM2 ganglioside. That's a lipid molecule, no? That's a lipid compound. And then, yung site of accumulation niya sa neurons and retina lang. Kaya yung kanyang clinical manifestation ay sa retina and sa nervous system lang, no? So here we have a cherry red spot kasi nag-accumulate yung GM2 ganglioside sa retina, so namumutla yung retina at na-emphasize yung cherry red spot sa macula. Yung Niemann-Pick naman, sphingomyelinase deficiency ang defect, no? Kaya nagkakaroon ka ng accumulation of your sphingomyelin. Now, yung accumulation ng sphingomyelin sa Niemann-Pick, nangyayari siya aside from neurons and retina, nangyayari din siya sa liver, sa spleen, sa reticuloendothelial system. Kaya, nagkakaroon ka ng hepatosplenomegaly in your Niemann-Pick na hindi mo nakikita sa Tay-Sachs. Okay? Now, in Gaucher disease naman, it's the most common lysosomal storage disorder. So, ang defect dyan ay glucocerebrosidase deficiency. Remember that deficiency kasi yung Gaucher at saka yung Parkinson disease, yan ang link nila, no? Yung glucocerebrosidase deficiency. Tapos, we have 3 clinical forms, no? Yung 1, yung chronic sa adults, yun usually skeletal system, yung kanyang manifestation and visceral. While yung 2 na acute, ay infantile and CNS ang manifestation. And then, there's an intermediate between 1 and 2. That's your type 3. And then, ang tatandaan nyo dito sa Gaucher is yung Gaucher cell nyo na may characteristic crumpled tissue paper cytoplasm. So, it's a large phagocyte with that characteristic crumpled tissue paper cytoplasm. Okay? Now, for your alkaptonuria, now this is an amino acid inborn error of metabolism, no, of your aromatic amino acids, your phenylalanine and your tyrosine. So, ang nangyayari, wala kang homogentic acid oxidase, and that homogentic acid accumulates and is converted, no, to your ochronotic pigment. So, characteristic niyan, yung urine ng may alkaptonuria nagiging itim pag stinand mo, no, and nagkakaroon sila ng arthritis. Okay? Okay, yung X-linked recessive disorders naman, usually males express the phenotype kasi ang kailangan lang nila ay isang copy ng recessive allele na X chromosome, no? Ang babae kasi, para magkaroon ka ng manifestation, kailangan 2 X chromosome na recessive allele, okay? Kaya usually, males yung nag-express ng phenotype kasi isa lang kailangan nila. But your females can also express the phenotype kasi remember, merong nangyayaring inactivation of 1X chromosome, no, sa babae. So, pag ang na-inactivate ay yung dominant, di patay, no? Kaya magkakaroon siya ng sakit. Now, yung X-linked dominant disorders naman, andyan naman yung mga crosses niya. Tandaan nyo lang na may 2 disorders na notably X-linked dominant ang pattern of inheritance, yung Alport syndrome at saka yung vitamin D resistant rickets. Okay, so let's go to chromosomal disorders. We know that we have 22 pairs of autosomes and we have a pair of sex chromosomes. So 46XX for females and 46XY for males, and that is considered euploid. So pagka may mali sa number na yon, then that is aneuploidy. Okay? So, chromosomal disorders can involve autosomes or sex chromosomes. Now, yung aneuploidy, pwede siyang mangyari in 2 situations, no? Number 1, before yung generation ng gametes mo, no? So, pag nagkaroon ka ng problem in your gametogenesis, then yung defective gamete na yun yung magpa-participate sa zygote formation. And then, lahat ng cells na manggagaling din sa zygote na yun ay aneuploid kasi dala-dala nung gamit yung problema, no? Now, yung errors post-fertilization, so normal sila lahat, pero somewhere along the way, after makagawa ng zygote, nagkaroon ng aneuploidy. And therefore, some cells will become normal and some cells will become aneuploid. And that's what you call your mosaicism. Okay? Now, first off, we have your trisomy 21. So, it's the most common of your chromosomal disorders and the leading cause of mental retardation. Okay? So, alam nyo naman yung itsura, no, ng patients with trisomy 21. So, here, gusto ko lang i-emphasize yung brush field spots, no? Ito yung characteristic findings in your eye findings in your Down syndrome. So, para siyang white or gray spots dun sa may periphery ng iris. Okay? Tapos, naka siya, parang annular. Okay? And then, meron din silang simian crease. So, aside from mental retardation, they also have other defects, no? Sa CVS, yung pinaka-common yung atrioventricular septal defect. And it's responsible for majority of deaths in infancy and early childhood. They can have Hirschsprung, they can have atresias in the GIT, they can have leukemias, they can have early onset Alzheimer's, and they can have autoimmune disorders, no? So bakit merong link ang trisomy 21 at Alzheimer's disease? It's because the amyloid precursor protein gene is in chromosome 21. So pag nagkaroon ka ng extra copy nun, yun, mas pabor na magkaroon ka ng Alzheimer's disease. Now, meron tayong trisomy 18 and 13. Halos magkamukha sila, no? They have a lot of visceral defects. They have rocker bottom feet. But cleft lip will differentiate, no? Your Patau syndrome, yung 13, no? From your Edward syndrome. Okay? Now, yung trisomy 18 and 13, hindi sila nabubuhay ng matagal. Usually, they die within the first year of life. And that is in contrast with your trisomy 21. Kasi in trisomy 21, pwedeng tumanda, no? Okay? Disorders of sex chromosomes. Okay? So, yung autosomes, di ba parang ang dami nilang abnormalities. For disorders of sex chromosomes, well, usually they're better tolerated, no? But since sex chromosomes yung problem, the problem is regarding sexual development and your fertility. And syempre, nagiging sexually mature lang naman tayo pag nagpo-puberty, no? Kaya doon mo lang siya na-diagnose. Okay? So, first off, we have your Klinefelter syndrome. So, ito, mga lalaki sila kasi meron silang Y chromosome. But then, meron silang extra, no? Meron silang extra X sa buhay nila. Kaya, ayun, nagulo ang buhay nila. So anyway, ito yung manifestations ng Klinefelter syndrome. Okay? So meron din siyang CNS manifestations pero hindi mental retardation. So medyo may konting mababa lang yung cognitive abilities nila. Pero hindi naman sila mentally retarded, no? Okay, so yan, reviewin nyo na lang siya. Now for your Turner syndrome naman, ito mga babae sila, no? Kasi wala silang Y chromosome, no? So, ang problem sa kanila, kulang sila ng isang X, okay? Kulang sila ng isang X, that's the most common abnormality, so 45XO, okay? And that will cause female hypogonadism. So, yung ovaries nila hindi nagde-develop, syempre yung secondary sex characteristics nila hindi rin nagde-develop, no? Okay? They also have webbed neck because of the cystic hygroma na nag-regress. And the cardiovascular disorders are the most important cause of mortality, no, in children with your Turner syndrome. They also have renal abnormalities, no, like your horseshoe kidney and etc. Okay, so reviewin nyo na lang yun. Now, yung hermaphroditism at saka pseudo-hermaphroditism, pag true hermaphroditism, pareho kang may ovary and testes. Pero pag pseudo, there's just disagreement between your phenotypic and gonadal sex. So, for example, in androgen insensitivity syndrome, ikaw ay lalaki, okay? 46XY ka, but then because your tissues are insensitive to androgens, parang female yung katawan mo, no? Yung, at least the external. Okay? Or the phenotypic. Now, kung ikaw naman ay genotypically female tapos meron kang male phenotype, so parang in the case of congenital adrenal hyperplasia, so you have 46XX, but because of the increase in your sex steroids in your congenital adrenal hyperplasia, medyo nagmumukhang penis yung clitoris, no? So lumalaki siya kaya parang napagkakamalan siyang lalaki. Okay? Remember, your congenital adrenal hyperplasia is female sila, no? 46XX. Now, trinucleotide repeat disorder. So, let's start with your Fragile X syndrome. Okay? So, following trisomy 21, it's the second most common cause of your mental retardation. So, the trinucleotide repeat is your CGG in your FMR1 gene in your X chromosome. So, meron siyang, yun nga, may mental retardation, and ang mnemonic ko dito is malaki yung lahat sa kanya, no? Malaki yung face, malaki yung jaw, malaki yung ears, malaki yung yag balls, and malaki ang topak nila, no? So, they have aggressive behavior, okay? And aside from that, meron pang ibang neuropsychiatric manifestations, okay? Now, yung Huntington disease naman, i-discuss naman natin to sa neurologic disorders sa CNS, no, sa chapter 26. Okay? But the defect is the trinucleotide repeat is your CAG, no, in your Huntington gene, and it's a combination of a rapidly progressive dementia with movement disorders. More of that on chapter 26. Tapos, Yung mitochondrial disorders naman natin, ipapaubaya ko na yun sa chem. But ang distinctive feature niya ay maternal inheritance kasi extranuclear yung material. And most of our extranuclear material nanggagaling sa ating mother. Okay? And ano ba yung nasa mitochondria? Diba electron transport chain? Kaya usually, mga defects in electron transport chain yung meron doon. So these are your examples. No? Now, for your disorders of genomic imprinting, imprinting is a process wherein, di ba meron tayong na-inherit na 2 copies ng gene. Okay? Tapos, yung isa doon kasi, nasa silence, no? So, the problem arises when the non-silence gene, so yung functional gene, ang na-delete. Okay? Leaving you with a non-functional or the imprinted gene. Okay? So, yun yung nangyayari in disorders of genomic imprinting. So, meron tayong 2 representative examples, your Prader-Willi syndrome, no, Prader paternal, Angelman maternal, but both involve chromosome 15. So, aside from mental retardation, meron tong endocrine, no? Meron siyang endocrine problems, no? May hypogonadism, obesity, no, profound hyperphagia. While your Angelman syndrome naman, mostly neurologic siya, no? And you have this characteristic happy puppet face. Okay? Okay, so diseases of the immune system naman tayo. So yung immune system natin, meron tayong innate and adaptive immunity. So your innate immunity, medyo marami siyang members compared to your adaptive immunity, which is only composed of your T and B lymphocytes and the antibodies, no? Now your innate immunity, nandyan lang yan lagi, and it responds, no, to any offending agent. So it's less specific and the potency of response is less. Okay? While your adaptive immunity naman, it develops later, no, and develops after antigen exposure, no? And dahil ito ay naka-tailor sa isang offending agent, therefore the specificity of the response is there, no? And it's more potent. Also, adaptive immunity has memory. Okay? So these are the other cells of your innate immunity, no? Your dendritic cells, these are antigen presenting cells, no? While your NK cells, these are the lymphocytes of your innate immunity. Kasi 'di ba yung nasa adaptive immunity natin, yon yung T and B cells. While your natural killer cells are in your innate immunity. Okay? So for your T lymphocytes, no, meron tayong 3 kinds, no? Your helper T cells, yung helper T cells natin nagpo-produce yun ng cytokines which modulate the inflammatory environment. So yung mga cytokines yung nagko-control, no, nung reactions ng inflammation. And then yung cytotoxic T cells naman, sila yung capable of directly killing the offending agents or the cells of interest, no? And then your regulatory T cells, ito yung mga suppressor, no? Suppressor T cells, these curb the immune response. Okay? Now, ang dami-daming CD dyan, but you have to just remember the important CDs in your T cell activation. And these are your 3, 4, 8, and 28. So your CD3, it's present across all T cells, while your CD4 and CD8, depende kung anong type siya, kung CD4 or CD8 siya. And then your CD28, no, it recognizes your antigen-presenting cells. Okay? Now, for your B lymphocytes naman, they're special because they're the only cells in the body that are capable of producing antibodies, well, not directly, because they will differentiate, no? They will differentiate into antibody-producing plasma cells and sila talaga yung nagpo-produce ng antibodies. Now, meron din tayong mga important CDs in your B cell activation and these are the following, no? Your CD79A, B, CD21, and CD40. Now, your CD79A and B, yan, present naman yan sa lahat. It's a pan-B cell antigen, no? And then your CD21, it recognizes complement products and it's important din kasi makikita nyo din, may encounter nyo din si CD21 sa Epstein-Barr virus, no? Now, antibodies naman. So, ano ba yon? Ito yung mga proteins. Now, these are mediators of humoral immunity that are produced by plasma cells, no? So, ito yung structure ng antibody natin. It's a Y-shaped molecule, no? Traditionally, ganun siya dinedepict, no? Now, meron tayong 2 region, no? Your antigen binding segment and your fragment crystallizable. So, yung antigen binding segment, yun yung sanga, no? Tapos, yung tangkay na main, yun yung FC, no? Now, important yung FAB because of ito yung nagbabind dun sa antigen. And then yung FC, ito yung nagbabind dun sa effector cells, no? Like your macrophages and your neutrophils para magkaroon ng inflammatory reaction, no? Or phagocytosis. Now, for your heavy chain naman and your light chains, meron silang constant and variable regions. Now, the variable regions are responsible for antibody binding to the antigen. So, basically, antigen binding, no? And then yung constant region ng heavy chain, that determines kung anong isotype siya. Meaning kung IgM, A, G, D, E ba siya, no? Now, your light chain naman, the constant region of your light chain determines the antibody subclass, yung kappa or lambda. Kasi in reactive conditions, for example, a benign inflammatory condition, we produce both kappa and lambda. But if we have multiple myeloma, we produce either kappa or lambda lang. And that's what we call your light chain restriction. Okay? Now, yung types of antibodies natin, we have your iso, your allo, and your idio. Now, your iso, it's the type found in all animals in a species, no? So, lahat ng tao may IgM, G, A, D, or E. Okay? And then, yung allotype naman, found in some but not all animals. And then, yung idiotype naman, it's a highly individualized antibody. Kasi ito na siguro yung nag-bind doon sa mga antigens. Kaya nag-iba-iba na siya ng configuration. So, very, very specific na yung idiotype. But tandaan nyo yung isotype, no? Yung M, G, A, D, or E. Okay? Now, what are the properties of antibodies? Recall lang natin ang immune nyo, no? Complement fixation. So, they're capable of activating the complement cascade. Now, there are two isotypes that are capable of that. Your IgM and your IgG. Now, the A, D, and E cannot fix complement. So, ang tatandaan nyo lang dyan, MG. Your mother geese. Charot. So, your mother geese can fix your complement, no? Now, doon sa 5, ang capable lang of transplacental passage ay yung IgG. Okay? Alam nyo naman yon. Now, affinity versus avidity. Your affinity, it's the initial force of attraction between a single FAB site and a single antigenic determinant site. So, the keyword here is single. While your avidity, it accounts for all, no, the antigen binding sites and antigenic determinants. Okay? Now, diseases of the immune system. So, tapos na tayo dun sa backgrounder information. Now, for the diseases of the immune system, we have 2, no? Either sobrang OA ng immune system mo or hindi siya nagpa-function at all, no? So, on one hand, if you have excessive unregulated activity of your immune system, then those are your autoimmune diseases. And then, kung decreased or absent activity naman siya, then that is your immunodeficiency. Now, your hypersensitivity reactions in your autoimmune diseases, they will present with damage, no, to your organs because of immune-mediated injury, while your immunodeficiency syndromes, they will present with infections, no? So, we have 4 types of hypersensitivity reactions according to your Gel and Coombs classification. So, the first one is your type 1 hypersensitivity, also called your IgE-mediated hypersensitivity or your allergies. So, sino dito yung mga may allergies? Okay? So, alam nyo naman na pag nakakain tayo ng allergen or na-expose tayo, mabilis tayong mag-react. And that is because we were previously sensitized, no? Na-experience na natin sila before, kaya tayo nag-mount ng response against them. And then, kapag na-encounter natin sila, allergic response na yung meron tayo. Okay? So, kapag na-encounter natin yung allergens natin, meron tayong 2 phases of reaction. No, the immediate is dominated by your vascular changes because of the vasoactive amines produced, no? While the late phase is dominated by inflammation, no? So, andyan na yung mga eosinophil, and of course, if you have your white blood cells, magkakaroon ka ng tissue damage. Okay? So, anong nangyayari? The first time you encounter an antigen, your naive T cells will differentiate into your Th2 cells. Now, your Th2 cells will produce your IgE and then magbabind yan dun sa mast cell. So, sensitized na tayo by then. No, now, if we encounter the next time, no, yung allergen natin, yung allergen will complex with the bound IgE in your mast cell, which causes it to degranulate. Now, pag nag-degranulate yan, lalabas yung mga inflammatory mediators, no? And yun yung responsible for the morphologic changes na nakikita nyo sa inflammation, like your vascular dilation, edema, smooth muscle contraction. Now, these are caused by your vasoactive amines, and the mucus production, inflammation, and tissue injury, these are caused by the inflammatory cytokines, no? Okay, so these are your examples, no? Your anaphylaxis, asthma, hay fever, or allergic rhinitis, and your food allergies. So the rest, yung asthma, allergic rhinitis, and your food allergies, these are also called your localized anaphylaxis, no? Now, for your antibody-mediated or type 2 hypersensitivity, we have three mechanisms, A, B, and C. So, yung A is opsonization and phagocytosis. Okay? So, yung IgG and C3b, no, these are opsonins. They coat your target cells and then, alam nyo yung mga fragment crystallizable ng IgG saka yung C3b, may yung mga effector cells natin or mga phagocytes, no, mga inflammatory cells, na-recognize nila yon yung mga coated nating cells, no, noon. Kaya, ipa-phagocytose nila or ilalize nila. Okay? Now, yung 2B naman or inflammation, yan, ang mangyayari dyan, your antibodies, remember in your chapter 2, you know that your antibodies can activate your complement. So, pag nagkaroon ng complement activation, you know that you produce your anaphylatoxins, no? So, nagkakaroon ka ng increased vascular permeability and inflammation. Okay? Now, for your 2C naman, your cellular dysfunction, no, wala namang nangyayaring tissue damage, but kapag nag-bind yung antibody doon sa target niya, na-alter yung physiology ng cell, no? Kaya ka nagkakaroon ng sakit. And a good example of that is your Graves' disease, no? And your myasthenia gravis. Okay? So, these are the examples. So, ma-encounter nyo naman yan later on. So, wag na natin yung i-discuss. Okay? Now, your immune complex-mediated hypersensitivity naman, ang nangyayari, alam nyo naman na yung immune complex, no, ay pwedeng makatrigger ng complement activation at pwedeng makakos ng inflammation, no? So, yung mga immune complexes na yan, para yung basura, kakalat-kalat yan at pwedeng ma-deposit anywhere. But they're concentrated in sites where there is blood filtration, such as your glomeruli and your joints, no? Kaya usually yung mga nephritis natin, mga type 3 hypersensitivity yung mga yan. And because they tend to be deposited in your blood vessels and their blood vessels everywhere, no, the diseases tend to be systemic except for your arthros reaction, no, which is local. Okay? So, yung morphology, of course, will be vasculitis kasi doon nga nangyayari, no, yung inflammation. Okay? And these are your examples. Now, for your T-cell mediated hypersensitivity naman, we have your CD4 and your CD8. Remember that your CD4 T-cells, they produce your cytokines, no? So, ganun yung kanyang mechanism. Okay? So, pwede kang magkaroon ng pwede kang mag-diverge, pwede kang mag-diverge into two lines, no? Kapag nagkaroon ka ng exposure to an antigen. Pwedeng TH1 or pwedeng TH17. Now, for TH1, nagsisecrete siya ng interferon gamma and that activates your macrophages, no? So, your macrophages will become epithelioid cells, will become Langhans-type giant cells, so magiging granulomatous inflammation yan, no? And that is the pathophysiology of your tuberculosis. Okay? Now, kung TH17 naman siya, magpo-produce siya ng ibang cytokines. Among them is your IL-17. And if you recall, in your chapter 2, your IL-17, they recruit your inflammatory cells, kaya ka nagkakaroon ng inflammation. Okay? Now, for your CD8 naman, remember that your CD8 T cells are capable of killing. So, and these are the mechanisms that they use. Now, your perforins, your granzymes, etc. No? And these are your examples. Now, let's go to your autoimmune diseases. So, ano ba yun? Auto, self-immune. So, ibig sabihin, yung immune system natin, inaatake yung sarili nating tissues, no? Supposedly, under normal circumstances, our body tolerates our self-antigens, but sometimes hindi. And doon nangyayari yung autoimmune diseases. Now, paano ba yun nangyayari, no? Well, it's either, syempre, meron yung genetic and environmental component, no, yung kung nakamana ka ng susceptibility genes, no, and if you have increased self-antigen burden. And yung mga antigens na yon, minsan nakatago lang sila, but when you have infections and your tissue damage, ang nangyayari na i-expose sila sa immune system at yun yung nagiging trigger ng autoimmunity. Now, sometimes there are offending agents, no, like for example, your streptococci, no. Now, your streptococci, sometimes they have things, no, in them, they have substances in them that closely mimic, no, yung structure ng self-antigens natin. And that is what you call your molecular mimicry. So, kapag nandun na yon, yung yung kamukha niya, ibig sabihin, maa-atake din yung self-antigen na kamukha niya, no? Yun yung dahilan kung bakit ka nagkakaroon ng autoimmune disease kapag molecular mimicry. So, just memorize itong mga to, be familiar with them, yung mga HLA alleles na yan, no? Now, let's go to your SLE. So, yung SLE classic yan, high yield disease, no? Parang lagi naman yung lumalabas. Okay, so it's a classic example of your type 3 hypersensitivity reaction, no? Most of the organ damage is because of immune complex deposition, except for the hematologic manifestations, your anemia, your thrombocytopenia, because those are antibody-mediated, particularly your opsonization and phagocytosis. So, ang hallmark ng SLE, marami siyang autoantibodies. And these are those, no, autoantibodies. Ang dami niyan, okay? So, ANA, anti-Smith, anti-dsDNA. Remember that your anti-nuclear antibody or your ANA, it's sensitive but it's not specific, and it's a required criterion as of 2019. While your Smith and your anti-dsDNA are specific for SLE, but your anti-dsDNA is correlates with nephritis. Okay, so mas may value siya. Now, yung antihistone for drug-induced, ROLA for neonatal lupus, congenital heart block, and you have your antiphospholipid antibodies. Okay? Didiscuss natin yung APAS later. Okay? So, sa morphology, ang tandaan nyo, usually yung mga naka-ano na lang, no? Yung mga naka-bold face. Na, syempre, sa blood vessels, type 3 yan, so alam mo na vasculitis yung kanyang morphology. Now, for the lupus nephritis, ito yung algorithm na ginagamit ko. So, tinitingnan ko muna kung ano yung deposit niya. Kung saan nakalagay, no, yung deposit niya. If it's in the mesangial area, you look at the light microscopy. Kung normal, that's class 1. If there are mesangial findings, then class 2 yon. Now, pag subepithelial, that's automatic class 5. For subendothelial, it depends, no, the magic number is 50. If there's involvement of less than 50% of your glomeruli, that's focal lupus nephritis, no, and then if at least 50, that's diffuse lupus nephritis. Okay? So, again, yung mga naka-bold face na lang yung mga tandaan nyo, yun yung mga usually high yield. Okay? Now, ito yung classes of lupus nephritis. So, sinabi ko na, diniscuss ko na yan kanina dun sa may algorithm. But I want you to look at this class 4, no? Your wire loop structure. So, ito yon. Nakikita nyo, thickened yung kanyang basement membrane, kaya parang yung capillary wall, kaya nagmumukha siyang wire loop, no? So, yun siya. Okay, and you have the 6th type, your advanced sclerosing lupus nephritis, characterized by sclerosis of more than 90% glomeruli. And these patients will present with end-stage renal disease. Okay, now for your clinical manifestations or clinical features, ipapaubaya ko na yun sa IM, but this is the memory device since time immemorial, no, your SOAP Brain MD. Meron lang siguro yung minor changes in your 2019 EULAR ACR classification. Now, aside from your classic systemic lupus erythematosus, we have other forms of your LE. Pag chronic discoid, skin manifestations lang siya. Okay? Skin manifestations lang siya. Pag subacute cutaneous, meron siyang widespread skin manifestations but you have mild systemic symptoms. Okay? And then, yan yung mga autoantibodies na meron siya, no, your SSA. And then, associated siya with your HLA-DR3 allele. And then, for your drug-induced, you have your HIP, no, your hydralazine, procainamide, isoniazid, and D-penicillamine. And again, as previously mentioned, antihistone antibodies yung meron siya. Okay? Now, for your APAS naman, ito yung features niya, no? You have your antiphospholipid antibody, of course, and then you have thrombosis and pregnancy loss. Okay? So, yun. Ano ba nangyayari? Your antiphospholipid antibodies, when they interact with your endothelial cell, no, they activate your endothelial cells. And when you activate your endothelial cells, nagiging thrombotic yung endothelial cells mo. No, they will promote thrombosis. Now, also, your antiphospholipid antibodies interfere with the normal trophoblast growth and differentiation. And therefore, that explains the pregnancy loss. No? Now, what's so weird about APAS is that in the labs of APAS, no, when you work up your patient, you will have a prolonged APTT, but the patient clinically presents with thrombosis. And the explanation for that is your antiphospholipid antibodies interfere with your phospholipid-based coagulation assays. That's why parang hindi siya nagko-coagulate. Kaya ang tagal-tagal ng APTT mo. Okay? Pero clinically thrombosis ka. Now, for your Sjogren syndrome naman, it's an autoimmune disease directed against your lacrimal and your salivary glands. You know that these produce tears and saliva. So, wala kang tears and wala kang saliva. No? So, it's a T-cell mediated reaction, no, against an antigen expressed, no, in your glands, or a virus, no, a virus that infects the said glands. Okay? So, yung autoantibodies ng Sjogren syndrome naman ay anti-Rho and anti-La. And between the two, yung anti-Rho, yung mas tandaan nyo kasi yun yung pang-toxic pag mataas yung titers niya. No? You have early disease onset, longer duration, extraglandular presentation. And remember that your Sjogren syndrome is associated with your rheumatoid factor. No? Now, early findings, madali lang to. Ang Sjogren, pag early, chronic inflammation. Pag late, fibrosis. Okay? Yun na yun. And the other findings are explained by the loss of secretions. No? Because when you destroy your lacrimal glands and your salivary glands, mawalan ka ng secretions, and yun yung secondary changes, no? May drying ng corneal epithelium, may fissuring, may ulceration, because wala kang lubrication. Okay, for your systemic sclerosis naman, ibig sabihin maraming fibrosis throughout the body, no? And ang pathogenesis nito, it's a T-cell mediated autoimmune disease, no, against an unknown skin antigen. Okay, and the effect is, kapag nag-react yung ating T-cells doon, ang mangyayari, magpo-produce tayo ng pro-fibrogenic cytokines, kaya ka nagkakaroon ng fibrosis. It's also accompanied by some degree of your vascular damage. Now, we have two clinical forms, your diffuse and your limited. Now, for diffuse, you have widespread skin involvement and early visceral involvement, no? And the opposite is true for your limited ones, no? So, for your diffuse cutaneous, ang autoantibody niyan is anti-DNA topoisomerase 1 or anti-SCL70. Now, for your limited, particularly your CREST syndrome, which stands for calcinosis Raynaud, esophageal dysmotility, sclerodactyly, and telangiectasia, anti-centromere antibodies naman. So, tandaan nyo yon. Now, for systemic sclerosis, this is a busy slide, but in terms of morphology, ang tatandaan nyo lang ay fibrosis. Okay? Madaming fibrosis. Okay? Now, for your mixed connective tissue disease, mixed, diba? So, overlap siya. Yung features niya ay overlap ng SLE, systemic sclerosis, and your polymyositis. And it has a special autoantibody na associated sa kanya, yung anti-U1 ribonucleoprotein. Okay? Now, let's go to transplantation immunology naman. So, review muna tayo ng types of grafts. So, pag autograft sa self, no? Pag isograft, identical twin. Pag allograft, other than your identical twin, pero tao pa rin, no? Kasi dapat same species. And for xenograft, different species. So, yun usually mga porcine valve, di ba? Mga ganon, no? Now, rejection ang pag-uusapan natin in your transplantation immunology because this is significant, no? So, ano bang nangyayari sa rejection? Yung recipient nire-reject niya yung graft. Okay? So, ito yung pag-aaralan natin, yung kidney rejection. Yun yung ating model organ, no? For the patterns of your rejection. Okay? So, we have 4 patterns. Your hyperacute, acute cellular, acute antibody-mediated, and your chronic. So, yung hyperacute at saka acute antibody-mediated ay mediated by antibodies, of course. And your acute cellular and your chronic are mediated by your T cells, no? So basically, ang pinakaiba lang naman nila ay onset, but they all have the same clinical presentation, which is hindi gagana yung kidney, okay? Hindi gagana yung kidney. So for hyperacute, immediately post-transplant, ang nangyayari kasi you have preformed antibodies from your donor and inaatake niya yung vessels ng kidney. Now, if you damage your vessels, they become prothrombotic and nagkakaroon ka ng thrombotic occlusion and you will have kidney infarction, no? Kaya cyanotic mottled anuric kidney yung nakikita mo immediately post-transplantation. Now, yung mga ganitong kidneys, hindi na sila pwedeng magamit, okay? Now, acute cellular and acute antibody-mediated, pareho silang may inflammation but iba lang ang sites, no? Your acute cellular sa tubules, interstitium, sa may endothelial cells, while your acute antibody-mediated usually sa glomerulus. Okay? Now, for your chronic naman, alam nyo na, syempre, mga thickening, fibrosis, mga ganyan, atrophy, no? Usually, yun naman yung nangyayari kapag may chronic rejection ka. Okay? Now, your hematopoietic stem cell transplantation, ginagawa siya if you have a diseased bone marrow, no? Like your hematologic malignancies, bone marrow failure syndromes, etc. No? So, part of the process of your HSCT is myeloablation, wherein papatayin mo yung laman ng diseased bone marrow, papatayin mo yung mga yon. Okay? So, anong gagawin mo? Ikikimo mo sila or radiotherapy. So, these cells are very sensitive to chemo and radiation and mamamatay sila because of this. Now, since you don't have any blood cells, you render your patient immunocompromised, no? And that is one complication of your HSCT. Now, another, which relates to immunodeficiency, is that when you get transplanted with immunocompetent cells, they can attack you, no? And that is what you call your GVHD. Okay? So, your GVHD, ang nangyayari, it's a battle between your transplanted immunocompetent cells and you as an immunocompromised host. Okay? So, anong inaatake ng GVHD? Usually, the tissues with high epithelial cell turnover or high cell turnover, no? Like your skin of epithelia of the skin, your liver, your intestines, no? And your immune system. So, dahil dyan, ang manifestation ng acute GVHD ay damage dito sa mga organs na to. So, for the skin, usually may rash. For GI, usually may bleeding. Ganon. Okay? Now, for your chronic GVHD naman, syempre, when something is chronic, edi magfa-fibrose yan. So, yung skin mo, magkakaroon ng fibrosis. No, your liver, pwede kang magkaroon ng obstruction kasi nag-fibrose na yung yung bile ducts mo. Pwede kang magkaroon ng GIT strictures. Anything that relates to fibrosis. Okay? Now, for your immunodeficiency diseases, no? So, we have the innate immunity, primary immunodeficiency states, okay? So, pag innate immunity, di ba, usually leukocytes, no? The phagocytes, your neutrophils, no? In particular. So, here we have your leukocyte adhesion deficiency. Alam nyo naman ang adhesion, it's mediated by your integrins, di ba? Yung rolling, selectins. So, pag may selectin integrin abnormalities ka, you will have your LAD, no? And because of that, you will have an impaired neutrophilic response. Okay? Hindi kasi pupunta dun sa site of inflammation yung mga neutrophils because stuck sila sa vessels. Okay? So, these are the clinical features, usually bacterial infections, and yung delayed separation of umbilical cord is quite characteristic. And then for your Chedia-Higashi syndrome naman, ang problem is phagolysosome function. So, kailangan mo mag-fuse with your with your lysosome to form the phagolysosome para ma-destroy mo yung phagocytize mo. Well, it doesn't happen in your Chediac. Kaya nga, ang meron sa kanya, puro giant granules in your cells. No? Kasi yun yung mga hindi nila ma-destroy. Okay? Now, hindi lang naman yung mga leukocytes ang nagre-rely sa phagocytosis. No? Madami din. Yung melanocytes, nerves, platelets. Kaya pwede rin sila magkaroon ng albinism, nerve defects, and breathing disorders. Now, for your chronic granulomatous disease naman, it's X-linked recessive. Now, ang problem naman dito is the respiratory burst, no, ng phagocytes. Kasi pag yun yung nagde-destroy mismo, no? Yung oxidative or respiratory burst. Now, if you don't have NADPH oxidase, then you will not generate adequate amounts of your free radicals needed for your respiratory burst, no? So, hindi effective yung killing mechanism ng iyong neutrophils. And it has a characteristic clinical feature of being susceptible to catalase-positive organisms because yung natitirang hydrogen peroxide na pwede sana niyang magamit, no, to kill that bacterium, ang problem, ginagamit nitong catalase-positive bacterium. So, nawawala, no, yung peroxide na sana pwedeng gamitin ni white blood cell, no, for the respiratory burst. Kaya, susceptible sila to catalase-positive organisms. Now, for your adaptive immunity, we have your Bruton agammaglobulinemia. So, this is B for Bruton. So, the defect is Bruton tyrosine kinase gene in your X chromosome and it causes failure of B cell maturation. So, alam nyo na kung anong kasunod, no? Pag wala kang B cells, wala kang plasma cells, wala kang antibodies of all classes. Okay? And you will present with respiratory and GIT infections kasi ito yung nagre-rely sa antibodies dun sa mucosal defense, no? Kaya usually, ganyan yung kanilang infection profile. And usually, they get symptomatic at about 6 months of age because the maternal antibodies are depleted. Okay? Now, for your DiGeorge syndrome naman, the defect is your chromosome 22q11 deletion, and that results in failure of development of the pharyngeal pouches where your thymus and parathyroid glands are derived. And it results in a catch-22. So your cardiac abnormalities, abnormal fascies, thymic hypoplasia or aplasia, cleft palate and hypocalcemia or hypoparathyroidism. No? So because your thymus is hypoplastic or aplastic, hindi nagde-develop yung mga T cells mo, wala kang T cells, so you're susceptible to fungal and viral infections, no? Because kailangan mo ng cell-mediated immunity to combat these infections. Now, they're also found to be associated with neural tube defects like your myelomenincocele. For your SCID naman, both arms are affected, no? Now, we have two patterns of inheritance. Your X-linked recessive, which involves a cytokine receptor defect, no? Which is needed for the signal transduction pathway for lymphocyte maturation. Now, pag nawala yon, pag nasira yon, walang magmamature na lymphocyte, no? Tapos, yung autosomal recessive naman, it's because of an enzyme deficiency, no? Your adenosine deaminase, which causes accumulation of your 2-deoxyadenosine, and this is toxic to your rapidly dividing lymphocytes, no? Kasi kailangan yan for nakaka-impair siya ng DNA synthesis, no? So, walang nagmamature basically na lymphocytes. And therefore, marami siyang infections, no? Yun. Basically, marami siyang infections and you have failure to thrive because the energy na dapat sana gagamitin mo for growth, nagagamit mo for combating infection because combating infection is an energy-expensive process, no? Also, because you're very immunodeficient, no, your maternal T cells na napunta sa baby can attack the baby. So, pwede ka magkaroon ng GvHD. Okay? Now, other immune disorders, no, for adaptive immunity, for isolated IgA deficiency, no, nagmature naman yung ating B cells, but the problem is in the class switching to an IgA producing plasma cell, no? So, hindi nangyayari yun. Okay? Now, you know your IgA is important for your mucosal defense, no? Kaya usually, ang infection profile nila, RESP, GIT, GUT infections, no? Kasi kailangan mo yung mucosal IgA for their defense. Also, these patients, nag-anaphylaxis sila pag naka-receive sila ng IgA-containing blood products. Kaya dapat i-wash mo yung RBC pag magta-transfuse ka sa kanila to get rid of the IgA. Now, for your Wiskott-Aldrich naman, WASP gene yung problem, and it presents as a triad of thrombocytopenia with small platelets. Yan, tandaan nyo. Siya yung may small platelets. Tapos, recurrent infections and eczema. So, siya yung tie, di ba? How to tie a WASP, no? So, thrombocytopenia, infections, and eczema. Actually, may DIAN, death, no? Okay. And they also have increased risk for lymphomas. Your ataxia telangiectasia, ang defect naman dyan ay yung ATM gene, and ATM gene is responsible for DNA repair, so therefore, nagkakaroon ka ng impaired DNA repair. Now, you also have an increased risk for lymphomas kasi yung DNA repair, important yan, no, in your lymphocyte function kasi pag nagsosomatic hypermutation sila when they encounter an antigen, no, para hindi sila maging lymphoma, kailangan mo ng DNA repair. So, pag nawala yon at nag-hypermutate sila, pwede silang maging lymphoma. Okay? Now, let's go to AIDS. Okay? Now, AIDS is the most serious secondary deficiency and these are the at-risk groups. Alam nyo naman na yan, no? Now, the etiologic agent is your human immunodeficiency virus. It's a retrovirus, no? Genus lentivirus. And these are the important structures of your HIV. You have your P24. Importante yung P24 kasi yan yung dinedetect sa screening test, no? For the latest generation of your HIV assays. Important din ang GP160. It's composed of your GP120 and your GP41, which is important for your attachment and your fusion respectively. Okay? So, ano bang nangyayari? No? Transmission of your HIV occurs via sexual route. No, it's the most common. Pwede ring parenteral when HIV is directly inoculated into the blood or pwedeng vertical transmission. Now, for your sexual transmission, Yon. Pwede siyang ma-inoculate sa blood vessels. Siyempre, yung sexual act, traumatic yon, no? So, nakaka-traumatize siya ng blood vessels and pwedeng ma-inoculate doon. Or, pwedeng ma-traumatize niya yung epithelium and then pumunta siya doon sa dendritic cells which are antigen-presenting cells. And the dendritic cells will go to the lymphocytes, no? To present yung HIV doon at doon namang yun yung magiging reservoir of infection, no? So ang nangyayari yung GP120, it binds to your CD4 and your chemokine receptors, your CCR5 and your CXCR4, no? And that's the reason why HIV infects your CD4 cells kasi kailangan niya yung CD4 receptor. Now yung CD4 receptor na yon, hindi lang siya nakikita sa CD4 T cells, nakikita din siya sa macrophages, no? So sa macrophages and sa dendritic cells, sa monocytes, no? Kaya nai-infect din niya yung mga cells na yon. Okay? So basically, it follows the lytic cycle, no? The lytic viral cycle, the usual. Okay? And then, what are the target systems of your AIDS? No? The primary targets are your immune system and your CNS. So, alam nyo naman na yung CD4 bumabagsak, no? Kapag meron kang AIDS. And that is mainly due to the direct cytopathic effect because they infect CD4 T cells, diba? And they lyse there. Okay? Now, your polyclonal B cell activation also happens. So, dumadami yung B cells mo pero they're not functional. Okay? And sometimes, nagkakaroon ka pa ng autoimmune phenomenon. And that can be explained by your Epstein-Barr virus infection, your viral GP41, and your IL-6 from your HIV-infected macrophages. Basically, dumadami yung B cells mo but they're dysfunctional, no? And in your CNS, nakakarating siya sa CNS when they infect your monocytes and then they travel there, no, sa CNS, and then they also infect your CNS macrophages which are your microglial cells, no? And yon na i-infect mo yung CNS na. Okay? So what's the natural history of AIDS? Meron tayong 3 phases, no? Your acute, your chronic, and your AIDS. So for your acute retroviral syndrome, ang nangyayari dito, tumataas yung viral load mo. So nagkakaroon ka ng viremia and then meron kang initial decrease in your CD4. Now, medyo nagkakaroon ka ng increase in your CD4, no, after that, and nagkakaroon ka ng drop, no, in your viral load because of the CD8 response, no, and the humoral response. So basically, magre-respond ka yung immune system mo against the HIV, and that's the reason why bumabagsak yung viral load and yan, tumataas yung CD4 ng kaunti. But then it enters the chronic phase where there is a slow but steady decline in your CD4 and wala kang clinical manifestations dito or very subtle. And then meron kang gradual lang na increase in viral load, no, kahit papaano. Okay? And then this phase lasts for 7 to 10 years. Now after that, biglang boom. Okay? Tataas ulit yung viral load mo and biglang super babagsak ng mabilis yung CD4 mo. And yun na yung AIDS, no? So, diyan ka na magkakaroon ng AIDS-defining illnesses. And then, typically, the phase lasts for 2 to 3 years before you die. Okay? Now, ang AIDS, marami yung sakit na kaakibat, no? Your AIDS-defining illnesses, may 2 groups yan. You have your infections, and these are the following, no? And you have your neoplasm. So, there is a double burden of disease in your AIDS patients. Okay? Now, for your laboratory diagnosis of your HIV, nabanggit ko kanina na important yung P24 because aside from your HIV-1 and HIV-2 antibodies, your P24 is also detected in your initial screening test, no, for your HIV. Okay? And this is the algorithm provided by the CDC. Okay? Now, for your amyloidosis naman, yan, magkakaroon ka ng amyloid. Okay? Magkakaroon ka ng amyloid. It's a starch-like substance, no, that accumulates extracellularly. Now, pag nag-accumulate yon, pwede niya kasing makompress yung normal tissue. And that's the reason kung bakit ka nagkakaroon ng organ dysfunction. Now, saan nanggaling yung amyloid na yon? It's either you have this abnormal protein, no, na hindi mo matanggal or pinoproduce mo ng sobrang dami. Okay? And these are your select types of your amyloidosis. So, ipapaubaya ko na sa inyo to go through them, ha? Okay? So, morphology, no? In terms of morphology, your amyloid, pink yan siya. Okay? Pink yan siya on H&E. And malalaman mong amyloid siya pag stain mo siya ng Congo red kasi magre-red siya. And if you subject it to polarized microscopy, you have your characteristic apple green birefringence. Okay? And ang clinical features ng amyloidosis, of course, ay organ dysfunction or organ damage. Now, in terms of renal, 'di ba? You can have renal failure, and that's the common cause of death, no? It's also the most common and potentially most serious form of organ involvement. Now, in your cardiac, pag nag-deposit yan doon sa myocardium mo, magiging matigas yung myocardium mo, so you will have restrictive cardiomyopathy. And because it involves the heart muscle where the conduction system is housed, no, you will also have arrhythmias. Now, for GIT, yun, lalaki yung iyong dila and magiging rigid. So, basically, parang ganun din, no? And then, for vessels naman, pag nag-deposit yung amyloid sa vessels, humihina siya, no? So, ang nangyayari, prone siya sa rupture, kaya usually nagkakaroon ka ng bleeding. You will encounter that in your CNS when we discuss your cerebrovascular disorders. And that ends your immune system chapter. So, neoplasia naman tayo. Okay? Very important lecture because a lot of the things that you're going to study in your systemic pathology are tumors. Okay? So, importante na maintindihan nyo tong neoplasia. Okay? So, definition of terms lang, actually self-explanatory naman to. But I would like to expound on some concepts. Okay? So, yung tumor components natin, we have your parenchyma and your stroma. So, ito, here in our example na desmoplastic small round cell tumor, we have our parenchyma, which is yung nest ng tumor cells. Ito, tong violet na to. And then yung paligid niya, yung kulay pink, yan yung ating stroma. Now, ang mapapansin nyo, collagenous, no? Or fibrotic yung ating stroma. Okay? And that is what you call your desmoplasia. It's a stromal response to the malignancy. And that's the reason why matigas yung mga malignant tumors. Okay? So, the greatest question, no, the most important question in neoplasia is, benign ba yan o malignant? No? So, yun. Pag benign, alam nyo na, di ba? Hindi siya kumakalat, nandyan lang siya, madali siyang tanggalin. Pag natanggal mo siya, okay na. No? Yung malignant, kumakalat yan. So, yan yung mga cancer. Yan yung bad. Okay? So, in terms of nomenclature, kailangan maintindihan nyo yung nomenclature, no? Kung paano pinapangalanan nyo yung tumors. Okay? So, OMA, pag sinabing OMA, mass yun. Okay? So, it's a tumor. And in itself, it's usually benign, except for the following, no? Na nakikita nyo dyan sa inyong screen. Because these tumors are malignant by convention. Your lymphoma, seminoma, hepatoma, or hepatocellular carcinoma, melanoma, and your mesothelioma. Now, for a malignant epithelial neoplasm, ito yung carcinoma. Tapos, pag malignant mesenchymal neoplasm, ito yung sarcoma. So, your bone and soft tissue malignancies, sarcoma ang tawag doon. Now, pag lymphoma, it's a malignant lymphoid tumor that forms a mass. Kaya siya lymphoma. Okay? And then yung leukemia, blood, no? So, nakikita mo yung mga malignant hematologic cells mo in your blood, or pwede namang nasa bone marrow lang sila. Okay? Now, itong blastoma and the other tumors, ma-encounter nyo naman yan sa systemic pathology. So, i-reserve na lang natin yan doon. But I want to concentrate on your hamartoma and your choristoma. So, pag sinabing hamartoma, yung tissues na yon ay nakikita talaga dun sa site na yon, pero disorganized siya. An example is your hamartomatous polyp in your Poids-Seeger syndrome. So, meron ka ditong intestinal glands, meron ka ding smooth muscle na nakikita mo naman talaga sa intestine, pero gulo-gulo siya. Okay? Gulo-gulo siya. Now, for your choristoma naman, no? Your choristoma naman, orderly yung tissue but it's in a wrong place. Okay? So, for example, we have here a mecal diverticulum. So, makikita nyo yung lining niya ay pang bituka, pang small intestine. But then, meron kang ectopic gastric tissue. Okay? So, para matandaan nyo yung hamartoma versus choristoma, ginagamit ko lagi yung dresser analogy. So, pag meron kang dresser, tas ang nakalagay doon ay damit, pero gulo-gulo siya, that's hamartoma. Pero pag choristoma, pag meron kang dresser, tapos ang nakalagay doon ay shoes, pero nakaayos. Okay? Now, paano ba natin nasasabi kung benign o malignant yan, no? So we have things that we look for. So one, differentiation, gaano siya kamukhang normal? Okay? Gaano siya kamukhang normal? Okay? So usually kapag malapit siya sa normal, no, well differentiated yon, and usually mga benign yon, usually, okay, usually mga benign yon. For example, we have here a follicular thyroid adenoma. So this is a tumor composed of your thyroid follicular epithelial cells. Nagpo-form din sila ng thyroid follicles, as in mukha lang talaga silang normal thyroid. Okay, so yan ang perfect example ng differentiation. Now, on the other hand, we have anaplasia, and that is lack of differentiation. So, an example is an anaplastic thyroid carcinoma. Pero pag tinignan mo yan at hindi mo alam na thyroid yan, anong sasabihin mo? Di ko alam, basta pangit yan, malignant yan. Okay? Yun. So, that's what you call your anaplasia, and it's a hallmark of malignancy. Metaplasia, we have already discussed. So, mag-skip tayo doon. Now, dysplasia, pag sinabing dysplasia, disordered growth. Okay? Disordered growth, pangit architecture, pangit cytology, no? But confined within the epithelium. So, pagka naman confined pa rin sa epithelium pero full thickness na ng epithelium yung involved, that is your carcinoma in situ. Now, a perfect example of that is this DCIS or ductal carcinoma in situ of the breast. So, as you can see, yung malaking duct dyan, no, na merong central necrosis, yung epithelium niya makapal, tas pangit, disorganized, so dysplastic. But then, you also have here a boxed area na may invasion, which is yung tumor cells nag-invade na beyond the basement membrane and it invades the surrounding tissues, no? So this now is a microinvasive carcinoma. Okay? So your local invasion is the second most reliable feature after METs, no? That differentiates benign from malignant tumors. While your METs is the spread of a tumor to sites that are physically discontinuous with the primary tumor. So, it's an equivocal marker of malignancy. Pag may METs, malignant yan, sure yon. Okay? So, this one is a metastatic colorectal carcinoma to the lung. So, makikita nyo, ito yung cancer, no? Tapos, yung surrounding niya, lung tissue yon. So, syempre, di naman malapit yung colon sa lung, di ba? So, that's METs. Okay? So, ngayon, under the microscope, paano namin nasasabing malignant ang isang bagay, no? And I will introduce you to a term called atypia. Now, this is a catch-all term, no, that describes how ugly the cell or a structure is. Okay? And usually, pag pangit, mukhang malignant yan, no? Pangit, malignant, pangit. Okay? Yan ang tatandaan nyo. Pag pangit, usually malignant yan, unless proven otherwise. Okay? So, paano mo masasabing atypical ang isang something, no? So, pleomorphism. So, pag sinabing pleomorphism, variation in size and shape. So, ibig sabihin, magkakaiba ang size, magkakaiba ang shape. So, pag tumingin ka dito sa example na to, mukha bang magkakapareho yung cells? Hindi, diba? So, that's pleomorphic. Okay? Now, for abnormal nuclear morphology, malaki ang nucleus. Usually, iba-iba sila ng itsura, like this, in this example, no? Hyperchromasia, some of them are very dark staining, as you can see there, no? Coarse or clump chromatin, may batik-batik na malalaki, no, within the nucleus. And then you have abnormally large nucleoli. Yung iba dyan, may mga mata, no, na malalaki sa gitna. Okay? And mitosis na pinopoint ng ating mga arrows, no? And we also have atypical or bizarre mitotic figures which are more specific to malignancies. Okay? Like in the top left, no, yung parang letter Y or your tripolar mitosis. Now, mitosis is not specific, in general, it's not specific to malignant process, no? Kasi syempre, may mga normal naman na nagpo-proliferate na mga normal tissues, no? So, usually, pagka-atypical na yung mitotic figures, medyo sure ka na malignant yun. Okay? Now, loss of polarity. This is a non-invasive papillary urothelial carcinoma high grade. Usually, orderly yung arrangement ng urothelium. But here, it's very, very disturbed. No? Yan yung tinatawag na loss of polarity. And also, necrosis. So, in leiomyosarcoma here, as you can see, yung right niya buhay pa, no? You have your nuclear details, pero yung left side niya kulay pink na lang and enucleate. So ito yung ischemic, no, coagulative tumor necrosis, characteristic of your malignancy. Okay? Now, paano ba ako makalat ang cancer? So, depende, no? Kung ang cancer ay in direct communication with the body cavities like your ovary, 'di ba? Na in close contact with the peritoneum, pwede kang magkaroon ng direct seeding. But typically, your carcinomas, they are spread through lymphatics, and your sarcomas, they spread through hematogenous. No, with some carcinomas that can also spread via hematogenous route. No, your 4 carcinomas, yan, yung 4 carcinomas route hematogenously. Okay, so follicular thyroid, CA, choreo, renal, and liver. Now, the renal and liver, well, kasi maraming vessels doon. So, talagang di mo maiiwasang kumalat via vascular. Okay? Now, cancer epidemiology, it can change, but in Robbins, ito yung mga most common. Okay? Basahin nyo na lang yan. Now, how do cancers come, no, to being, come into being? Okay, so it starts with mutations. Okay, so mutation, alteration of a genetic material of the cell, and whatever the mutation is, it only has one unifying trait for cancers: unregulated growth and proliferation. Okay, so we have two general types of mutations. We have your driver and your passenger. So pag driver mutations, these are the more important ones because these are the mutations that confer characteristics that make a cancer, or what we call your cancer hallmarks, while your passenger mutations are just products of genetic instability. Okay? Now, what are cancer hallmarks? So, madami yan, no? Ang una dyan, yung self-sufficiency in your growth signals. So, di nila kailangan ng environmental trigger, no? Kaya na nilang mag-produce ng growth signals by themselves, no? Okay, so here we have your proto-oncogenes. Now, your proto-oncogenes, these are normal genes, okay? Yung normal genes na yon, usually, ang process na hinahandle nila ay growth and proliferation, but they are regulated. Now, pag nag-mutate yon, it becomes an oncogene. Now, that one is the abnormal gene that is unregulated, no? And its gene product is what you call your oncoprotein. Now, remember RAS because it's the most common type, no? Of abnormality involving proto-oncogenes in human tumors. Now, also, normally, no, we have your tumor suppressor genes. And these genes, pinipigilan niya yung tumor growth, no? So, pinipigilan niya yung proliferation, yung growth. Now, if you remove those tumor suppressor genes, then unregulated yung growth. And yun yung nangyayari in cancers. Now, so we have two important tumor suppressor genes, your RB and your TP53. Now, your RB, no, it regulates your G1 to S checkpoint in your cell cycle. And if you remove that, dire-diretso ang cell cycle, dire-diretso ang proliferation. Now, so some of the cancers associated with your RB loss include your retinoblastoma and your osteosarcoma. Now, for your TP53 naman, it's the guardian of the genome and it's the most frequently mutated gene in human cancers. Now, how does TP53 function? Okay, now we have 3. Kapag may na-encounter yung severely damaged cell, it induces cell cycle arrest para mag-repair. So, tumigil ka muna. Repair mo muna yung sarili mo. And then, kung hindi na kaya, tigil siya. No? Titigil talaga ang growth niya, and that is your senescence. Or if super damaged na niya and it's not allowed to survive, then mamamatay siya via apoptosis. Now, we have MDM2. It's a p53 inhibitor. And that means, if you have MDM2 amplification, pag marami kang MDM2, may inhibit yung p53 mo, no? Kaya magkakaroon ka ng tumors. And that's the case in your well-differentiated liposarcoma. And just remember your Li-Fraumeni syndrome from many tumors. Okay? Tapos, altered cellular metabolism. Your cancer cells, they are wired differently, no? Imbis na energy ang i-produce niya, ang fini-favor niya ay carbon skeleton. And yung carbon skeletons kasi, kailangan mo yung gamitin para makabuo ka ng maraming cancer cells, no? Yun yung tinatawag na Warburg metabolism. Now, there are other minor things that are altered metabolically in your cancer cells, all of which, ang aim naman niya ay mag-produce ng cancer cell. Okay? Now, evasion of apoptosis, di sila namamatay dahil in-evade nila yung apoptosis either by increasing your anti-apoptotic factors or decreasing your pro-apoptotic factors, no? Now, they're immortal, no? And because they have the ability to evade senescence, no? Kaya lagi silang nagpo-proliferate, no? And they maintain their telomere length. Your telomere length is proportional to your lifespan, no? So, kung may telomerase ka, it maintains the telomere length, then buhay na buhay ang cell forever, no? And in each round of replication of your cancer cells, one of them becomes a stem cell, no? Kaya preserve ang stem cell pool ng cancer, okay? Kaya sila immortal. Now, sustained angiogenesis, of course, your cancer cells, they have the capability to produce their own vasculature para ma-nourish naman sila, no? And they also are capable of invasion and metastasis and evasion of immune surveillance, kaya sila nagsasurvive. Normally, our immune system combats the tumor cells, no? Kaso nga lang masyadong matalino ang cancer cell. They have different mechanisms to evade the immune system, kaya nakakapag-thrive sila sa katawan. Okay? Now, what are cancer-enabling elements? These are not hallmarks, but they promote the development of cancer. Now, genomic instability, self-explanatory. If you have genetic instability, you will have a lot of mutations, no, and you will have cancer. Now, for your chronic inflammation naman, this is one thing that you have to remember. Anything that's chronically inflamed can be at risk for cancer development, no? Okay? So, remember that. Now, carcinogenic agents, ito, padadaanan ko na lang to sa inyo, no? You have chronic inflammatory states. Infections can cause tumors by chronic inflammation, or in the case of oncogenic viruses, no, they produce oncogenic viral products, okay? And then chemicals can act as mutagens or promoters. Hormones can induce proliferation of hormone-sensitive tissues, which can lead to cancer eventually. And radiation are capable of causing mutations because of DNA damage. Now, etong mga conditions na to, ipapaubaya ko na sa inyo para basahin, no? Yan. Okay? The infections, ganyan, and ganyan. Kasi minsan may mga tinatanong dyan, no? Mga paisa-isa, dalawa. Sayang din yon. Okay? Now, clinical aspects of neoplasia. So, ang isang taong may tumor ay may tumor, no? Meron siyang mass usually. But sometimes if deep-seated yung organ, minsan wala ka makakapa. So, that's where imaging helps, okay? And also, aside from mass, syempre may mga surrounding structure sa katawan natin. So, pag may lumaking mass, sometimes pwede niyang ma-obstruct yung mga bagay-bagay, pwede siyang makakompress ng mga bagay-bagay. So, yun yung tinatawag na mass effect, and sometimes they can cause obstruction, no? So, cancer cachexia, yung mga may cancer, payat yung mga yan, no? So, ano ba nangyayari? Yung cancer, remember, it also has an inflammatory component, no? So, alam nyo naman, pag may inflammation, may cytokines, and nakikita nyo naman dyan, meron na naman tayong holy trinity of cytokines, your tumor necrosis factor, your interleukins 1 and 6, no? So, these are responsible for the systemic effects and also cachexia, no? Yung pamamayat nila. And then your paraneoplastic syndromes. If your mass effect is related to your anatomic distribution of your tumor, your paraneoplastic syndromes are unrelated to the anatomic distribution of your tumor. And these manifests because of the hormones that they produce, no? So the most common endocrinopathy is your Cushing syndrome. You usually see them in your small cell lung cancer because your SCLC produces ACTH, okay? And your hypercalcemia is probably the most common paraneoplastic syndrome, and it's because of your parathyroid hormone related peptide, okay? So, important ang mga paraneoplastic syndrome kasi usually, kahit di mo nakikita yung tumor, alam mong may mali, no? And it hints you, no, to a presence of a neoplasm. Okay? And also, itong mga to, syempre, in themselves, kailangan mo din silang i-manage. Okay? And then, tumor grading and staging. Pag sinabing tumor grade, it relates to how ugly it is, no? How ugly the tumor looks. Okay? Now, the grade is inversely proportional to the degree of differentiation. So, ibig sabihin, pag low grade, mas maganda, that's well differentiated. Pag high grade, hindi maganda, mas undifferentiated, those are your poorly and your undifferentiated tumors. Now, there are a lot of grading systems available depende sa tumor, no? And sometimes it's not hindi siya nagko-correlate well with prognosis, but there are some cancers that correlate well, no, with prognosis, yung grade nila. And a perfect example of that is your prostate cancer. Okay? Now, yung tumor stage naman is the more important of the two clinically, no, because ang tinetest naman nito ay kung gaano kakakalat yung tumor, no? Kung gaano kakakalat. Okay? So, syempre, pag high stage, mas makalat na yung tumor or was widely disseminated na siya. And most solid tumors follow the TNM staging system, the state of the primary tumor, presence of nodal and distant metastasis. Now, the primary tumor criteria vary, no, depending on what type of tumor we're talking about, no. For example, in GIT tumors, usually depth of invasion, and therefore magiging importanteng prognostic factor siya, no, in your staging. Okay? For breast naman, tumor size, no, kung gaano kalaki yung primary tumor, yun naman yung magde-determine ang prognosis. Now, tumor lysis syndrome, if the patient undergoes chemotherapy, magkakaroon siya ng electrolyte abnormalities because of the lysis of your tumor cells. Ang tandaan nyo lang dyan, ang mababa calcium, no? The rest, potassium, phosphate, uric acid, lahat mataas. Except calcium, mababa yung calcium. Now, because of the electrolyte abnormalities, you can have arrhythmias, you can have seizures, and because of the increase in uric acid load, no, or burden, you can have urate nephropathy, which can present as an acute kidney injury. Okay? Now, for your immunohistochemistry naman, or IHC, lagi nyo siyang may encounter, no, sa systemic pathology, dun sa next part. But this one is a histochemical technique that detects antigens in the tissue, no? So, yung cells natin, meron niyang different set of antigens. Yun na yung parang ID niya. So, yun yung mga hinahanap natin sa tumors. Okay? Kaya natin sila ina-IHC. So, what are the applications of this? Kapag meron kang undifferentiated malignant tumor, you need to do your IHC for you to determine kung ano yon. Because they can be these different differential diagnosis, no, can have different treatment modalities, and therefore you have to give your oncologist something that they can treat, no. Kaya usually pag undiff, IHC agad. Okay? Now, determination of origin of mets. Well, usually naman pag may history ka na, madali nang alamin kung ano yon. But kung wala, no, sometimes immunohistochemistry can resolve that, no, kung para malaman mo kung ano yung primary tumor. And detection of molecules that have prognostic or therapeutic significance, like your ERPR HER2 IHC for your breast cancers. So here in this example, makikita nyo yung HER2, it's expressed in the cell membrane. So makikita nyo, positive siya sa HER2. May kulay brown, no? So, anong implication yan? Pwede siyang mag-anti-HER2 therapy or your trastuzumab, no? Now, your tumor markers naman are blood tests. Okay? So, dinedetect niya yung mga substances na nasa blood, and that hints to a presence of a tumor. So, what are the applications? Make sure to take note of these. No? Screening, diagnosis, recurrence, mets or treatment response, and some tumors like your testicular tumors, no, needed tumor markers for staging. Okay? And then, ipaubaya ko na sa inyo to memorize these select tumor markers. And that ends your neoplasia chapter. Let's now go to your infectious diseases. So, diretso agad. Okay, viral diseases, your measles. So, it's caused by your measles virus from your Paramyxoviridae family. Okay? So there, because it has only one strain, pag na-infect ka na nito, immune ka na for life. Okay? So ano bang clinical picture ng measles? So you have your fever plus your treaces, your cough, coryza, and conjunctivitis, and then you develop this maculopapular rash that precedes cephalocaudally. Tapos, may kasamang fever na yon, no? Tapos, pag bumaba na siya sa paa, yung rash mo, magde-differvis ka na. Okay? So, ganun yung klase. Tapos, on physical examination, you will see your Koplik spots, no, in your oral cavity. And this shown right here in your on your screen is your Warthin-Finkel D cell. So, this is a multinucleated giant cell found in your measles, no? In your lymphoid organs, lung, and your sputum. And the complications of measles include your pneumonia and your encephalitis, particularly your subacute sclerosing panencephalitis. Now, for your mumps virus, another paramyxoviridae. So, anong inaatake ng mumps? Yag balls. Okay? Yag balls, salivary glands, and pancreas, and brain. Okay? Pati pancreas, remember. Okay? So, nothing special about the morphology of your mumps. Like usual viral infection, no? Malymphocyte siya, so mononuclear, with some edema and all that. Now, complications, remember, the most common extrasalivary gland complication of your mumps is your aseptic meningitis. And if you have severe testicular damage, then alam nyo na, nakaka-sterile siya. Herpes simplex virus. Okay? So, these are alpha herpes viruses. So, you have your HSV1 and HSV2. No? For your HSV1, oral. For HSV2, genital. But of course, because of variations in sexual practices, pwede kang magkaroon ng interchange, you know. Okay? And herpes can affect a lot of organs, no? Eyes, brain, esophagus, lungs, liver, name it, no? Now, cutaneous, no, na herpes are painful vesicles that can rupture and ulcerate, and the lesions are independent of dermatomal distribution, which differentiates it from herpes zoster, no? Now, morphologically, you have your Cauchy type A inclusion bodies, and these are pink to purple intranuclear inclusions. And also, you have multinucleated giant cells like in the photo shown here, no? You have a pap smear of herpes cervicitis. Okay? So, pag viral diseases, usually may mga cytopathic effect yan. So, inclusions, multinucleation, makikita nyo yan doon. Now, varicella and herpes zoster. Now, VCV is also an alpha herpes virus. Sorry, nabubulol ako. Okay? So, meron niyang two forms. Your varicella, yun yung initial. So, ano bang clinical feature niyan? You have your prodrome and then magkakaroon ka ng very makating rash, no, na may vesicles, no? And then, the distribution is centrifugal. So, from torso to extremities. Okay? And then, mag-rupture yon, mag-crush, and then mag-heal yung lesions. Okay? And then, magiging latent yun for several years until you have predisposing conditions which can reactivate, no, your varicella zoster virus in the form of herpes zoster. So, it's common in immunosuppressed. So, usually doon, pagka nagkaroon ka ng ganon, yun, magre-reactivate yung iyong VCV into zoster. Now, clinically, this presents with painful vesicular lesions, no, na dermatomal ang distribution versus yung herpes simplex na hindi. Okay? Now, so these are your complications. Madami yan. Ramsay Hunt, pneumonia, encephalitis, name it, no? But the most common complication of your herpes zoster is your post-herpetic neuralgia. So, kahit wala ka ng lesions, meron siyang pain doon, na dermatomal pa rin. Now, sa varicella, ano ba ang kanyang morphology? Vesicles, no? With cells na may intranuclear inclusions, no? Like this photo, no, shown here. Now, for CMV naman, it's a beta herpes virus. Bakit ba ako nagkakaroon ng defects lately? Pagpasensyahan nyo na ako. Okay? So, Marami yung type of infections depending on the age and immune status of your patient. Okay? So, kaya sila cytomegalovirus kasi malaki yung cells na na-infect nila, lumalaki sila. And they have this characteristic large intranuclear inclusions, no? So, owl's eye nuclei ang tawag. And then, you also have your small basophilic intracytoplasmic inclusions, no? Shown here in the photo. Ngayon, ano-ano ba yung mga severe CMV infections kung sinabi nyo na it depends on age and immune status? Now, these are the two scenarios na severe ang CMV infection. Number 1, if you have congenital infection wherein the mother has a primary CMV infection. Kasi wala pa siyang maternal antibodies na ipapasa sa baby. So, pag nakuha ng baby yung CMV, wala siyang defense. Kaya magkakaroon siya ng cytomegalic inclusion disease. Now, yung sunod is if immunocompromised. As in any other infection, kapag immunocompromised ka, mas severe, no, yung clinical manifestation. Now, let's go to Epstein-Barr virus. So, it's a gamma herpes virus. Now, it infects your V cells by binding to your CD21. Ito yung sinasabi ko sa inyo from chapter 5 na ma-encounter nyo ulit si CD21. Now, we have a benign disorder called your infectious mononucleosis, no? So, ang clinical presentation niyan, fever, sore throat, lymphadenopathy, no? And you have your lymphocytosis with atypical lymphocytes shown here in the photo, no? So, pwede mo sila mapagkamalang blast kung hindi ka experience magbasa, no? But they're benign, okay? Now, yung malignancies na associated with your Epstein-Barr virus are the following: nasopharyngeal carcinoma, Burkitt lymphoma, and some Hodgkin lymphoma types, no? I-discuss naman natin yan dun sa WBC disorders. Now, ang EBV at CMV, pareho silang may mononucleosis-like disorder, no? Pero ano bang pinagkaiba nila? Yung heterophile antibodies, positive siya sa Epstein-Barr, negative siya sa CMV, okay? Now, for bacterial disease naman, listeriosis. Okay? So, you have your Listeria monocytogenes. It's a gram-positive bacillus. No? So, it's transmitted by intake of contaminated food. And therefore, gastroenteritis yung presentation niya. Now, you have severe infections in your pregnant, neonates, older adults, and immunosuppressed patients. In pregnant, pwede kang magkaroon ng abortion, no? Stillbirth and neonatal sepsis. Pwede rin yun. And for your neonates, you can have a disseminated disease called granulomatosis infantiseptica, wherein you have this characteristic rash plus febrile gastroenteritis. And in immunosuppressed patients, you can have meningitis, pati in neonates. Okay? So, morphology, nothing special. Suppurative inflammation, no? As with any other bacteria, they can trigger acute inflammation, kaya ganon, no? Now, yung pertussis naman, it's a gram-negative organism, yung cause, no? Bordetella pertussis. So, yung clinical presentation nito, we have 3 phases: your catarrhal, your paroxysmal, and your recovery. Now, yung catarrhal, yun yung mild cough lang, sipon, no, and fever. Mild lang. And then, yung super ubo, nangyari yun sa paroxysmal stage, no? Kaya yun yung, dun yun nakuha yung whooping cough. And then, yung recovery naman, yun, dadalang na lang yung cough. Okay? And you will recover in 2 to 3 weeks. Nothing special din sa morphology, no? Kasi ganun din, may mucopurulent exudate, ganun din, no? Parang suppurative inflammation din. Okay, mycobacterial diseases. So, TB, Diyos ko, ang nakakasawang TB. Okay? So, it's the leading infectious cause of death worldwide, and it's caused by your Mycobacterium tuberculosis. Okay? So, nabanggit natin kanina sa immune na ang pathophysiology ng TB ay CD4-mediated hypersensitivity or immune cell response. No? So, TH1 particularly kasi CD4. No? Nagiging granuloma kasi, no? Okay, so morphology, if you have an intact cell-mediated immunity, meaning your T cells are functioning as they should, therefore you will have granulomatous inflammation because you need your CD4, di ba? But if wala kang CD4, then wala kang granuloma. So, yung mga TB bacilli, nasa macrophages lang sila. Okay? Now, we have other clinical forms. Kasi usually lungs yan pulmonary TB. Now, we have other clinical forms. Your lymphadenitis is the most common extrapulmonary. You have your Pott's disease. Lagi nyong naririnig yan. And yung GIT, where ileum is the most commonly involved. But since wala nang contaminated milk, less na yung incidence of your GITB. Okay? So, the components of your tuberculous granuloma is your central caseation necrosis, and then it's surrounded by your aggregates of your epithelioid macrophages or epithelioid cells, and then may scattered na Langhans type multinucleated giant cells, and then may outer rim of lymphocytes like shown. Okay? What are the clinico-pathologic forms of your tuberculosis? You have your primary and your secondary. They have their progressives and their miliary. So, some mnemonic lang na i-offer ko. For gone, it's ground floor, no? So, nasa baba yan ng lung, babang part ng lung. And then, it's the primary tuberculosis lesion, no? Now, for your secondary tuberculosis lesion, it's your Simon foci. So, S is for second floor. Nasa taas din siya. Okay? And remember lang na yung miliary tuberculosis is not synonymous with disseminated TB. Kasi yung miliary, it's a pattern of spread. So, for example, in your lung, you have miliary TB na pulmonary. Marami kang small dots, no, ng caseation throughout the lungs. Yun yung miliary. Pero yung disseminated, it's involvement of a lot of organs. Okay? Oh, yun. Now, bakit nga ba nagkakaroon ka ng hemoptysis, no, in your TB? It's because the infection is so destructive that it can erode into blood vessels. And pag nangyari yon, pwede ka magkaroon ng hemoptysis, no? Okay. Now, Mycobacterium avium intracellulare, ito naman, nangyayari to sa mga HIV patients or those with profound immunodeficiency, and therefore ang nakikita mo ay macrophages lang na punong-puno ng TB bacilli, no? They don't form granulomas because you need your cell-mediated immunity to form granulomas. Now, for leprosy naman, your Mycobacterium leprae. So, ang target naman niya ay peripheral nerves. No, we have two forms, your tuberculoid and your lepromatous, which also differ, no, in terms of the immunity, no, ng pasyente. So, for tuberculoid, you have intact cell-mediated immunity. You will form granulomas around your nerves. While for your lepromatous leprosy, no, you have depressed cell-mediated immunity. So, ang itsura niya ay ganito din, katulad ng MAC infection. Okay? So, for your tuberculoid leprosy, you have positive lepromin skin test. Para siyang PPD. So, it indicates that you have intact cell-mediated immunity. But for lepromatous leprosy, you will have a negative lepromin skin test. Okay? Which indicates that you don't have an intact cell-mediated immunity. Now, for spirochete infections, first off, we have your syphilis. No, it's caused by your Treponema pallidum. So, ang tatandaan yung morphologic hallmarks ng syphilis ay dalawa. Number 1, plasma cells. Number 2, obliterative and arteritis, like in this example in your photo. So, sa gitna, nakikita nyo yung isang vessel, wala na yung lumen. So, obliterated na siya. And there are a lot of plasma cells surrounding the vessels, no? So, yon. Now, what are the clinical forms of your syphilis? So, you have your primary syphilis, no? Genital yon. Genital ang manifestation niya, painless na chancre, and then it will spontaneously heal. Now, for your secondary syphilis, it's mucocutaneous involvement. So, you have your condyloma lata and others, no? Now, for your tertiary, you have your ABG, no? Aorta, brain, goma, no? So, your aorta is the most commonly involved, and then the other visceral organs, CNS, liver, bones, no? Testes can even be infected, no? Or affected. So, your goma, wala dito yung picture, but it's like a granuloma, but the central part is coagulative necrosis, not caseation. And instead of lymphocytes, mas maraming plasma cells. Okay? Syphilis, di ba? Okay. And we also have congenital syphilis, no, which happens when you have high organism burden, no. So ito yung manifestations niya. You have your bones, no, the saddle nose, saber shin, eyes, teeth, 8 nerve deafness, no. And sometimes they can have fetal death, no. Now, laboratory diagnosis of your spirochetal infections, dalawang phases yan. Usually, screening yung una with your non-treponemal test, your RPR and your VDRL. Now, pag screening, it's sensitive. So, ibig sabihin, pag negative, wala talaga. But pag positive, hindi ibig sabihin nun na syphilis ka, no? Okay? Pag positive yan, maraming other conditions that can cause a positive RPR. For example, pregnancy, autoimmune diseases, di ba? Infections, no? Pwede yon. And pwede rin sila mag-false negative if you have too much of antibodies or antigens kasi hindi magfo-form well yung gusto mong mag-form para makita mo yung positive test result, no? So that is your antibody or prozone and then antigen post-zone phenomenon. Okay? Now, kung nag-positive ka sa RPR, iko-confirmatory test ka by through your treponemal tests, no? So your FDA-ABS, your microhemagglutination. Now these are specific for Treponema pallidum. So an example of which is your FDA-ABS. So yan, naglight up yung mga spirochetes mo in your fluorescence microscopy. So alam mo na meron kang syphilis, no? Na-confirm mo. Okay? Now, Lyme naman, Borrelia. Borrelia burgdorferi most of the time for Lyme disease. And the vector is tick, no? Not just a tick. It's black-legged or deer ticks. Okay? So, ang una nangyayari is relapsing fever with lymphadenopathy. Very non-specific. But you have this erythema migrans, no? And ito yung itsura niya. Okay? And then, yan, pwede kang magkaroon na ng visceral involvement in the long run, no? So, skin, joint, muscles, etc. And then, remember, no? Ang Lyme disease characteristic niyan, arthritis. Okay? Arthritis. Now, for your leptospirosis naman, it's the most common zoonotic infection in the world, no? Now, Leptospira interrogans ang etiologic agent, and it's transmitted by exposure to infected urine, no, from the rat, no. Usually murine urine yan, no. And then meron yan dalawang phase, no. Your anicteric, yun yung parang non-specific flu-like illness, and then after that you will have your icteric phase wherein may liver involvement na, and then may renal failure. Yun yung hepatorenal syndrome na nakikita mo sa whale syndrome. Now, morphology, the most consistent feature is your capillary vasculitis. Okay? Now, for your rickettsia, ito din, vasculitis din to, no? So, ito yan, rickettsia, Orientia, Ehrlichia, Anaplasma, yan yung mga rickettsia and rickettsia-like organisms. And these are the diseases that they cause, okay? And their respective vectors. Now, nabanggit ko na vasculitis din yung kanyang lesions. It's because they love infecting endothelial cells. They love infecting those, no? So, yun yung magiging morphology. Vasculitis, may fibrinoid necrosis, no, may thrombosis, may hemorrhage. Okay, ganon. Now, in the lungs, if it happens, particularly in your Rocky Mountain spotted fever, then you can have, acute respiratory distress syndrome. And here is an example of your ARDS where nakikita mo na inflamed yung mga blood vessels mo, you have your vasculitis, and it somehow involved the surrounding pulmonary parenchyma, no, which causes damage of your alveoli, no, your lungs, and then it ultimately leads to ARDS. So nakikita nyo dyan, may hyaline membrane dyan sa may lining ng alveolar, no, sac. Okay. Now, fungal diseases, you have your Candida albicans. So, it's the most prevalent fungal pathogen of humans, no? You can have thrush, no? Superficial lang, andyan lang sila sa mucosa, or they can be invasive, especially in your immunocompromised patients. So, these are your yeasts, no? In your esophageal candidiasis, they're stained with your periodic acid shift. So, makikita nyo yung mga bright pink nyong yeast with your pseudo hyphae. Okay? Okay, environmental and nutritional pathology naman tayo. So for air pollution, of course, the lungs is the most affected kasi air pollution nga, 'di ba? So the common thing is once it gets into the lungs, no, it can injure your cells there and it can cause inflammation which can cause damage, no, parang ganon. Now for soot, no, or particulate matter, when it's really small, it can reach your distal airways and they're the most harmful. And this is the common pathogenesis of your pneumoconiosis, which we're going to discuss in your chapter 14. Kasi pag nakuha sila ng alveolar macrophages, ma-activate yon, magkakaroon ng inflammation and airway damage. Okay? Now, for your carbon monoxide is deadly because you cannot detect it. Okay? It's colorless, it's odorless, but it can cause systemic asphyxia. Okay? So, paano ito nakaka-cause ng disease? Your carbon monoxide can decrease your O2 delivery because it competes with binding, no? It competes with your oxygen in binding to your hemoglobin, and nananalo yung carbon monoxide because it has 200 times more affinity to your hemoglobin. It also decreases ATP production by inhibiting complex 4 of your electron transport chain, no, and therefore the common theme, no, of your morphologic findings in your CO poisoning is hypoxic changes, plus the characteristic cherry red discoloration of your skin and mucous membranes, which it owes to the cherry red color of your carbon monoxide. Okay, now the clinical features depend on the level of CO2 saturation. Pag 20 to 30, systemic hypoxia. Pag 60 to 70, you can die. Okay? So remember that when you have a patient with a cherry red discoloration, so kahit mapula sila, rule out your CO. Okay? Rule out your CO poisoning kasi baka mamaya ma-mislead ka into thinking na wala naman silang problem with oxygenation dahil mapula sila, no? Hindi lahat ng mapula ay may well oxygenated, no? And this is an example of that. Okay? Now for your lead is a divalent cation like your calcium, and therefore lead can also deposit in your bones and your teeth, and they can make your teeth weak and bones weak. Okay? So opposite ng ginagawa ng calcium. They can also bind to your proteins, which can cause organ toxicities, and they notably inhibit two key enzymes in your heme synthesis, your aldehydrate and your ferrochelatase, which can result in a microcytic hypochromic anemia with basophilic stippling and your ring sideroblast. Now, the ring sideroblast is a product of not being able to incorporate your iron into your heme because of the ferrochelatase thing. Okay? Kaya nasa stuck sila sa mitochondria and they become iron-laden mitochondria. Okay? Yun. Now, for GIT, you can have a lead colic, and neurologic manifestations depend on the age group. Usually, pag pediatrics, central nervous system problem. So, learning difficulties, mga ganyan. Now, pag adults naman, usually peripheral neuropathy like wrist drop, foot drop, and then you can have renal failure as well. Now, for your mercury naman, you have these forms, okay? And the sources are your fish, the methyl mercury, for example, So how does mercury cause disease? In the same way that lead causes disease, they can bind to your proteins, which can target your CNS and your kidney. So Minamata disease yung associated with your mercury. Minamata is for your mercury. So ang nangyari dito, yung mga nanay na pregnant, nakakain sila ng contaminated fish na may methyl mercury, and then nagkaroon ng CNS problems yung kanilang mga anak. Now, your arsenic naman, the poison of kings or king of poisons, the most toxic is your trivalent compounds. Now, it can interfere with your oxidative phosphorylation process. In glycolysis, in your pyruvate dehydrogenase, the dehydrogenases enzymes there, are inhibited by your arsenic. Now, marami siyang clinical features, but the most important that I want to emphasize is that it can cause cancer, particularly your squamous cell carcinoma of the skin, no? Kasi meron tayong tinatawag na arsenical keratosis. Ito yung pre-malignant condition that arises from arsenic exposure. Okay? Now, your cadmium naman can cause disease by ROS generation, and you know that ROS can destroy your tissues and your cells, no? So the target is kidney and your the kidneys and your lungs, no? So yung itay-itay disease, ang nangyari kasi dyan, once you have your renal disease, no, you can have improper calcium handling, and therefore you can have bone manifestations, no, which can clinically present with pain. Kaya siya itay-itay disease. Tobacco, no? So, alam na alam nyo naman yan, it's the most prevalent preventable cause of death in man. So, there are a lot of bad things about your tobacco, and nicotine makes you addicted, no, to your tobacco. Okay? So, appreciation lang. As you can see, there are a lot of bad effects, no, ng tobacco smoke. And maybe the worst is your carcinogenesis, no? And if you look at the effects of your tobacco, well, the most glaring is of course lung. Kasi nga syempre ini-inhale mo siya, no? So you can have obstructive lung diseases. You can have bronchial inflammation, no? And for CVS, it's one of the coronary risk factors, no? So it accelerates atherosclerosis, no, together with your hypertension, DM, and your hypercholesterolemia, and others. Well, also, of course, it promotes cancers in a lot of organs, particularly your lung, esophagus, pancreas, bladder, no, kidney, no, and others. Okay? So, iwasan yung mag-smoke. Yun lang ang ibig sabihin ng slide na to. Okay? Now, for your alcohol naman, we consume alcohol, no? Your ethanol. But there are some alcohols that we do not consume and we should not consume. And these are your toxic alcohols. So your methanol, ethylene glycol, and your isopropanol. Now, the most toxic ones are the parent alcohols, which are your methanol and your ethylene glycol. Okay? Now, your ethanol, of course, alam naman natin na iniinom natin siya. And actually, kung moderate consumption lang naman, actually healthy yon, no? Pero kapag madami na at chronic, ay doon tayo magkakatalo, no? Okay? So, ano bang nangyayari in the ethanol that we ingest, no? So, the ethanol is metabolized in our liver, okay, by these enzymes, okay? So, your alcohol dehydrogenase, siya yung main, okay? And it consists of your alcohol dehydrogenase, which converts your ethanol to acetaldehyde, and then your acetaldehyde is converted further to acetic acid. Okay? Now, in high levels of alcohol, then the CYP450 enzymes will come in, no? And that's your MEOS, your CYP2E1. And then catalase has a minor role. Now, your acetaldehyde is toxic, no? It can destroy your compounds, no, your lipids, and it can destroy your cells, can cause cell injury, no? And it's also the reason for alcohol intolerance. Now, yung CYP2E1 natin, well, it's a phase 1 metabolism, no? It's a phase 1 metabolism. So, nag-generate yan ng ROS. Okay? And that can also cause your cell injury. Now, if you look at the dehydrogenase reactions, they produce NADH. And your NADH, if you have a high NADH currency in your cell, no, it can shift the metabolism to inhibit gluconeogenesis and promote lipogenesis, which can cause hypoglycemia and fatty liver respectively. So ito yon, no? Ito yung nangyayari. If you have a high NADH currency, you will deplete yourself, no, ng mga substrates mo for gluconeogenesis. And also, if you have a lot of NADH, ano ba ginagawa ng beta oxidation? 'Di ba? Produce ng NADH. Okay, kasi nga beta oxidation, inoxidize mo yung fatty acids, no? So, produce ng NADH, no? So, pag marami ka ng NADH, magsha-shut down yung beta oxidation and it will shift the metabolism to storage, no? Or lipogenesis, no? Creation of your fat and storage of your fat. Kaya ka nagkakaroon ng fatty liver. Okay? So, ganon. So, ito, marami siyang effects, no? So, nakikita nyo, CNS depression, that's one of the acute effects of your ethanol. And also, your GIT erosions. Alam nyo naman, nakakasakit ng tiyan yan siya. Diba? And then, these are the other effects. So, basahin nyo na lang yan. Notably, your alcohol can also contribute to a lot of cancers, particularly your oral cavity, your esophagus, and your liver, no? Because of the fatty liver that it causes. Okay? So, tandaan nyo yon. Now, thermal injuries, burns, alam nyo naman na yan. Most common, thermal injury. Usually, fire and scalding scalding is a common cause in your children. Alam nyo na yan, may 3 degrees. So, usually, pag partial, mapula lang. Pag partial thickness, meron kang blisters, no? And when full thickness, talagang charged siya. Okay? Or your 3rd degree burn. So, ano ba ang causes ng mortality in your burn? Well, shock. Well, kasi nagka-burn ka, dinidestroy mo yung endothelium, no? Which becomes leaky. Kaya ka nagsha-shock. Okay? And also, syempre, fertile ground yan for infections pag nakita mo yung burnt skin. So, yun, isa yun sa pwedeng pumatay sa kanila. And also, respiratory insufficiency because of the fumes or because of the heat, no? Because of the heat or the noxious substances that they have inhaled, which can cause injury to their airways. Now, these are your hyperthermia syndromes. Your heat cramps, it's because of electrolyte loss through sweating, no? And then yung heat exhaustion naman, it's due to dehydration, no? So when you're dehydrated, mababa yung cerebral blood flow, kaya ka biglang nagko-collapse. Okay? And hindi kinakaya ng CVS compensatory mechanisms mo yung hypovolemia na yon. Now, for your heat stroke and your malignant hyperthermia, magkaiba siya ng slight. Okay? So, yung exertional heat stroke, ang nangyayari when you have strenuous exercise at a high temperature, then you will have increased reactive nitrogen species, which can cause nitrosylation of your RYR1 receptor. Now, yung malignant hyperthermia, it's a genetic one, no? Now, you have a mutated RYR gene, but when it only becomes very problematic when you get exposed to certain triggers like your anesthetics. So basically, regardless, no, of the differences nung ryanodine 1 receptor states nila, they're dysfunctional in such a way that they just throw their calcium into the cytoplasm. Kasi supposedly, yung ryanodine receptor, siya yung nagre-regulate ng pasok ng calcium ng labas ng calcium into the cytoplasm from the sarcoplasmic reticulum. Now, doon sa dalawang circumstances na yan, dyan sa dalawang diseases na yan, your calcium just goes out freely, no, through your ryanodine receptor. And you know that your calcium is like a master key, no, to a lot of metabolic processes that can generate heat, no, and all that jazz. Okay? Kaya ka nagkakaroon ng hyperthermia. So, these are the clinical features: hyperthermia, vasodilation, some electrolyte abnormalities which can cause also arrhythmias, and your rhabdomyolysis because of your sustained contraction. Okay? Now, for your hyperthermia naman, skip na natin yan. Okay? Now, ionizing radiation. Okay. Yung radiation kasi, meron tayong ionizing and meron tayong non-ionizing. Okay? Yung UV, iba naman yun, no? Yun yung for skin cancers because of the thymine dimer formation and DNA damage. Now, yung mga ionizing, they can also cause your DNA damage. And the triad of clinical consequences ng radiation ay cell death. Because if you have too much radiation, you have too much DNA damage, mamamatay yung cell. Teratogenesis. So, if you get exposed to radiation during the period of organogenesis, it can cause problems in the development of your organs, therefore causing teratogenesis. And sabihin na natin nakaligtas ka doon, no? So, in the adult life, kung buo ka naman, no, na-expose ka sa radiation, pwede ka naman magkaroon ng cancer. And here, you see that in the Chernobyl area, there's higher birth defect rates, no, because of teratogenesis, and there's a lot of incidence of, there's a high incidence of your papillary thyroid cancer in the area, no, dun sa may Chernobyl accident. Okay? So, ano bang effect ng radiation, no? The most susceptible are the lymphocytes, and that's the reason why we irradiate blood products, no? Para mawala yung lymphocytes that can cause transfusion-associated GvHD. Okay? Now, marrow, small bowel, no? They have epithelium, no? That are labile, no? Yung small bowel, di ba? Meron siyang epithelial cells. Yon, very proliferative yon. Bone marrow, may hematologic cells, very proliferative din. So usually yun yung mga susceptible to radiation. And then the least susceptible or the most resistant is the brain. Okay? Now, in terms of morphology, pag may radiation, ang isipin mo lang pangit. Okay? So, meron kang tinatawag na radiation atypia, and you can mistake that for malignancy. So, make sure that you know na may history ng radiation. And then, for tissues naman, you can have fibrosis and ischemic changes. Okay, syempre kapag nagkaroon ka ng vascular fibrosis, ma-obliterate yung lumen nun. So, mawalan ka ng supply dun sa area na yon, mag-infarct siya at magiging fibrotic, no, na scar in the end. So, yun yung tatlong morphologic changes ng radiation. Atypia, fibrosis, and ischemia. Now, for your malnutrition naman, no, your severe acute malnutrition, you have your marasmus and your kwashiorkor, no? Pag yung marasmus, your weight is 60% of normal or less, and it's because of the deficiency in caloric intake. Now, your marasmus patients are very thin because the somatic protein component is more affected, and therefore nagkakaroon ka ng wasting. Okay, now the albumin is relatively preserved. Now, for your kwashiorkor naman, it's more of a protein deficiency. And the protein compartment affected is the visceral one. So, these patients, they have low serum albumin and therefore decreased oncotic pressure, and you will have edema. That's why these patients are thin but they're heavier because of the manas, no? And they also have this flaky paint appearance for your skin, the flag sign for your hair, no? And there. Okay? Now, for eating disorders, your anorexia, so it's a self-induced starvation, no? And you can have endocrine abnormalities, no? And low bone density because of the endocrine abnormalities, because of your hypoestrogenic state. Now, your bulimia, it's more common, and you have purging and non-purging. Yung purging, vinavomit mo. Yung non-purging, super nag-exercise ka, o kaya nagda-diet pills ka naman, mga ganyan. Okay? And that can cause, no, particularly the purging type, can cause your aspiration kasi suka ka ng suka, or your esophageal and gastric rupture. Okay? And then for the vitamin disorders naman, usually yung toxicities happen in your fat-soluble vitamins because they can be stored. Yung water-soluble nyo, usually hindi naman, no? Itong table ng vitamin deficiencies, ipapaubaya ko na sa inyo para sa uluhin or i-familiarize nyo yung sarili nyo. Okay? Now, for your obesity naman, di ba meron tayong mga payat kanina, no? Yung mga kwashiorkor at saka marasmus. Now, this is the other end of it. Ito yung mga matataba to a pathologic degree. Okay? So, central obesity or the visceral obesity, no? Yun yung higher risk for mortality because it's more lipolytic, and therefore it can produce a lot of free fatty acids, no? And which can cause a high burden of inflammatory cytokines, no? Kaya meron kang pro-inflammatory state in your obesity. Okay? So, these are the general consequences of obesity. Ang pinaka-common naman dun talaga ay insulin resistance, no? Insulin resistance, your too much fat can disturb your insulin signaling, which can cause insulin resistance and type 2 DM. Okay? And then, marami pang iba. Okay? Now, obesity can also cause cancer. Well, alam nyo naman, di ba sinabi ko, pagka meron kang persistent pro-inflammatory state, when something is inflamed, pwede kang magka-cancer, no? And other than that, no, your insulin resistance can also play a role in your cancer by stimulating your RAS pathway. And also, your obesity can be a peripheral source of estrogen. So it can cause breast and endometrial carcinoma, the estrogen responsive ones. Now, it can also antagonize production of your adiponectin, which is actually a good molecule because it's anti-proliferative. So pag nawala yon, then cellular proliferation ang nananaig. Okay? So again, your obesity can cause a lot of things, and especially it can cause cancer then. So let's try to stay healthy. Okay? And that ends your environmental and nutritional path. Okay, last chapter ng GenPath, your diseases of infancy and childhood. Okay, so congenital anomalies, ang ibig sabihin ng congenital, it's present at birth, and these are the following definition of terms. Self-explanatory naman yan, but I would like to elaborate on a sequence, your Potter sequence. So a sequence is a cascade of anomalies triggered by one initiating aberration. So in this example, yung oligohydramnios or Potter sequence, yung oligohydramnios yung problem. Okay, and oligohydramnios can be caused by a lot of things, particularly your renal agenesis and your amniotic leak. Your amniotic fluid is like your fetal urine. So if you don't have kidneys, then you will not produce your fetal urine. Okay? And then if you have increased AF loss, due to amniotic leak, you can also have low amniotic fluid index or oligohydramnios. Now, that can cause a particular characteristic lesion in your placenta known as your amnion nodosome, but that's the least of your problems. So, your oligohydramnios can cause one, pulmonary hyperplasia. Okay? Ngayon, yung fetal urine kasi, nilulunok yan ng baby. And then that helps in the development of the lungs. So, kung wala kang fetal urine, hindi rin masyadong magde-develop yung lungs mo, kaya meron kang pulmonary hyperplasia. Add to that the fact na wala kang cushion that's provided by your amniotic fluid, and therefore you can have fetal compression, which can cause the following abnormalities. So, that is your oligohydramnios sequence. So, what causes congenital anomalies? Di ko alam, Most common cause is unknown, but the most common known cause is multifactorial, which is a combination of your genetic and your environmental factors. So, timing is everything in your congenital anomalies, particularly the first trimester. Now, if the insult is so severe, within the first 3 weeks, you can have abortion. And during the 3rd to 8 weeks, yun yung period of organogenesis, or 3rd to 9th week, pag na-expose ka dun sa teratogens or dun sa insults, then pwede ka magkaroon ng congenital anomalies. Okay? So, ipapaubaya ko na sa inyo tong mga to. Okay? But your rubella, we have a mnemonic there, butas ang puso, bingi, bulag, bobo, or if you want to be politically correct, then brain problem, So, basta meron silang 4 Bs. So, these are the different exposures, For your thalidomide, you can have phocomelia, fetal alcohol syndrome for your alcohol, and then for DM, you can have fetal macrosomia, So, yung malalaking baby. Okay? Now, prematurity. Okay, pag sinabing prematurity, ano ba yun? Less than 37 weeks MI, or maturity index. And then we have 2 complications that we're going to discuss. Now, your neonatal RDS and your necrotizing enterocolitis. So, your neonatal RDS or hyaline membrane disease is the most common cause of respiratory distress in your newborns. So, these are the risk factors, and notably, meron tayong maternal DM sa risk factor. The reason for that is when you have maternal DM, you have maternal hyperglycemia, and therefore, yung body mo kailangan mag-produce ng insulin. So, you will have maternal hyperinsulinemia, and that will also be transmitted to the fetus. So, you will have fetal hyperinsulinemia, and insulin is bad for your type 2 pneumocytes because it antagonizes their development. And your type 2 pneumocytes are needed for the production of your surfactant. And that is the defect in your neonatal RDS. So you have, aside from pulmonary immaturity, you have surfactant deficiency. No? Now, pag meron kang surfactant deficiency, your alveoli will collapse, okay? Because your surfactant decreases the surface tension in order to prevent alveolar collapse. So pag nag-collapse yan, you will have atelectasis. Now, a collapsed airway cannot be ventilated, no? And therefore, you will have ventilation perfusion mismatch. Now, the body will not perfuse that atelectatic segment because why? 'Di ba? Hindi mo naman pala ma-oxygenate di wag ko na lang dyan dalhin yung dugo, dalhin ko na lang sa mas magandang area ng lung, dun sa mas ventilated. Okay? And therefore, nagkakaroon ng vasoconstriction in that area and hypoxemia. No? And because of that, pwede kang magkaroon ng epithelial and endothelial damage. No? You know that hypoxemia or hypoxia can cause cell injury. Okay? Now, the cell injury can promote inflammation, no? And therefore, magkakaroon ka ng inflammatory debris there which will eventually organize into hyaline membranes. Now, the hyaline membranes will coat, no, the alveolar walls and therefore will make their walls thickened. Okay? And in your Poiseuille equation of your diffusion, if you decrease the thickness ng diffusing medium, then mas mababa ang diffusion. And therefore, that also aggravates the hypoxemia and CO2 retention and so on. Okay? So that's the pathophysiology of your RDS. So RDS lungs are like liver, no? They sink in water, they're airless, reddish-purple, solid. Okay? Now, here, microscopically, ang makikita mo yung mga hyaline membrane. So, pag hyaline, kulay pink, di ba, na homogeneous, coating your alveolar wall. So, ma-appreciate nyo ngayon na pag ganyang kakapal, yung didiffusan ng hangin, wag na lang. So, yun. Okay? Now, yun. Clinically, you have neonatal respiratory distress in a preterm or premature patient, and you have your ground glass appearance of your lungs on your babygram. Okay? Now, this is the reason why patients, no, yung pregnant patients natin are administered steroids, no, in 28 to 34 weeks of gestation to help with lung maturity. Well, after 34 weeks, nag-increase naman na ng mabilis yung surfactant production, so mas nagiging mature yung lungs. Kaya 28 to 34 lang. Now, yung mga RDS natin, syempre minsan ino-oxygenate sila, part yun ng therapy, no? Yung oxygen support. Now, because of that, you can have complications. One of them is your retinopathy of prematurity. Didiscuss naman natin yan doon sa eye. Pero sige, for now, yung hyperoxic therapy kasi, it can cause vasoconstriction. Now, pag nagkaroon ka ng vasoconstriction, syempre, mas mababa yung blood flow. And therefore, magkakaroon ka ng hypoxia sa retina. Now, that hypoxia is a trigger for neovascularization. Okay? And that can cause your retinopathy. That can cause your impaired vision. Okay? Now, yung bronchopulmonary dysplasia is another complication wherein the lungs are stuck at a saccular stage, no, of development. Now, necrotizing enterocolitis naman, no, it's associated with your very, very low birth weight infants and aggressive enteral nutrition. So, pag pinapakain mo agad. Bakit? Kasi yung pathogenesis niya, you lose your mucosal integrity because of ischemia, infection, and inflammation, no? And that permits bacterial transport, no, from intestine to the blood, and then nagkakaroon ka ng sepsis. Okay? So, yun yung neck. Now, if you do your early enteral nutrition, you administer bacteria to the gut early. And therefore, pag nagkaroon ka ng inflammation doon, yun yung magta-translocate, no? Yung bacteria na yun, magta-translocate to the blood, magkakos ng sepsis. No? And Your platelet activating factor is one of the implicated mediators that increases your mucosal permeability. So, syempre, necrotizing enterocolitis, alam nyo na, madugo yan. So, tumatae yan ng may dugo, and then you have abdominal distension, no, because of pneumoperitoneum. Because these organisms, some of them are gas forming and therefore can cause some mucosal gas bubbles to form, such as in this photomicrograph. And then in severe cases, pwedeng mag-rupture yung bowel, and then yung air pupunta sa abdominal cavity. You can have pneumoperitoneum in severe necrotizing enterocolitis. Okay? Now, fetal hydrops naman. So, you have accumulation of your edema fluid in your fetus. Okay? So, the first one is your immune, and then we also have non-immune causes of your hydrops. Now, for your immune, it's the hemolytic disease of the fetus and newborn, or HDFN. So, remember na yung fetal immune hydrops, yung mother walang antigen. Okay? Yung fetus lagi ang may antigen. So, yung mother na walang antigen, pag na-expose sa antigen ng fetus, okay, may immunize siya against the antigens of the fetus. So, magpaproduce siya ng antibodies that can attack the fetus. Okay? Kaya ka, particularly the red cells of the fetus, kaya ka nagkakaroon ng hemolytic anemia intrauterine. Now, bakit ka nagkakaroon ng edema? It's because of this, no? When you have your anemia, of course, you will have low oxygen levels. Now, the body senses this, no? And the heart will compensate for the decrease in oxygen by increasing your cardiac output. And therefore, pump siya ng pump. Pag napagod siya, magkakaroon ka ng high output heart failure and congestive heart failure. And that is the cause of the edema. Also, the liver, when they're affected by your hypoxic changes, no, it will decrease, no, protein synthesis. And you know, your albumin, diba? Sa liver yan sinisynthesize. So, pag wala ka nun, magkakaroon ka din ng edema. Now, naghemolysis ka. Ano ba yung nandun? Heme saka globin. Now, the heme will become bilirubin. And therefore, hemolysis will cause increased unconjugated bilirubin, no? And unconjugated bilirubin is lipid soluble and can readily deposit in the tissues, especially the lipid rich ones like your brain, which can cause kernicterus. Okay, so yun. Now, we have two setups, no, for immune hydrops. Your RH incompatibility, it's the most severe. Okay, so ang setup niyan, again, mother no antigen, so Rh neg, and then fetus has antigen, so Rh positive. And then it should be a subsequent pregnancy, because yung first pregnancy will be the sensitization phase. Okay, so if you have a previous pregnancy with Rh fetus and you've been exposed to the fetal red cells with Rh positive, then you develop anti-Rh antibodies. And then in the second gestation, the Rh antibodies will go to the fetus and will cause hemolysis of the fetal red cells, no? Now, swerte mo if you have concurrent ABO incompatibility, because those ABO incompatible cells are readily removed from the circulation and therefore prevent the chance, no, of alloimmunization. Okay? So how do you prevent Rh incompat, no, na HDFN? You introduce ROGAM at 7 months, no, 28 weeks, and within 3 days prior to delivery. Now, yung ABO is the most common cause, no, of HFDN, accounting to about 20% of cases. So again, same setup, walang antigen yung mother. So type O si mother. The fetus can be either BA or B. And then since the antibodies ng ABO are naturally occurring sa atin, then first pregnancy pa lang pwede ka magkaroon ng symptoms na, no? Pwede na maging symptomatic yung baby. So there's no effective prevention in contrast with your Rh incompatibility. Now for your non-immune hydrop, so tigil na tayo sa immune, no? Okay? So cardiovascular defects, no, and fetal anemia, yun yung dalawa. Now the cardiovascular defects kasi as long as it causes congestion, no? Congestion, then it can cause your hydrops. Yun. Now, for anemia, fetal anemia that is not caused by HFDN, no? Ano yun? Pwede kang magkaroon ng hydrops. In the same way, kasi di ba pag may anemia, high output heart failure, hypoxemia, ganun din. Okay? So the morphology is yun nga, generalized or localized edema. Now, hepatosplenomegaly, because if there is profound anemia, then magko-compensate ang spleen to do your hematopoiesis, kaya lalaki sila. That's your extramedullary hematopoiesis. Now, your erythroblastosis fetalis is the presence of your immature red cells in your circulation, and you release those immature red cells in the hope of helping, no, relieve the anemia. Yun yung effort, no, ng body. And then kernicterus only in your HFDN, kasi nga because of the hemolysis. Okay, so the brain is yellow and edematous. Okay, now cystic fibrosis, a very high yield thing, no? So it's the most common lethal genetic disease affecting Caucasian populations. Now, the defect is in the CFTR gene in chromosome 7, and it's an autosomal recessive disorder. Now, your CFTR is an ion channel, and depending on the tissue where it is, no, different yung movement ng ions across it. Okay. Now, if you have your CFTR in your sweat duct, now your sodium and your chloride will come in, no, preventing salt buildup in your sweat. Okay. Now, if you have cystic fibrosis, the chloride will not come in. If the chloride does not come in, then the Na will not come in either, and they will fuse to become salt. And that is the reason why you have salty sweat. Okay. Now, in your SP, GIT, and pancreas, normally, no, your chloride goes out, and then your sodium will go in, and it will bring water with it, no? Now, if you have cystic fibrosis, then the chloride will not go out, and therefore the interior of the cell will be more negative. In order to maintain electrical neutrality, then sodium will come in more, no, in order to make things neutral. And sodium, naghahatak yan ng tubig, and therefore yung tubig mas madami din. Okay? And where ano nangyayari dun sa mucus? Then the mucus becomes dehydrated, kaya ka nagkakaroon ng mucus plug. Okay? Now, for the pancreas, no, you have decreased bicarbonate secretion into your lumen, no? So the bicarbonate does not go into the lumen, and therefore you have acidic secretions. Now, that acidic secretion can promote precipitation of mucin, which will contribute to your mucus plug formation, and also it will make them very favorable, no, for organisms to adhere to the mucus plugs. Kaya usually, yung mga may cystic fibrosis ay grabe ang infection. No? Imagine niyo na lang, recurrent sinopulmonary infections, name it. Okay? So, in keeping with the pathophysiology of your cystic fibrosis, mucus plugs, mucus plugs, mucus plugs. Okay? Yun. Except for salivary glands, because salivary glands, sweat glands pala. Except for sweat glands, because the sweat glands are normal, except maalat ang pawis nila. Okay? Now, they can also have congenital bilateral absence of your vas deferens. Now, clinically, di ba, ang sine qua non or something that they cannot not present with, so laging nandyan, is the salty sweat. So you detect that by measuring your sweat chloride levels. And of course, nabanggit nga natin dun sa pathophysiology niya na the acidic secretions will promote bacterial adherence, and therefore yung infections talaga glaring sa mga cystic fibrosis. So the pulmonary infection is the most serious manifestation. So these are the common organisms: your staph, your haemophilus, and your pseudomonas. They can also have pancreatic insufficiency because of the mucus plugs in your exocrine pancreas, which can cause pancreatic maldigestion and fat-soluble vitamin deficiencies, no? And then, because of the vast difference, no, you can have azoospermia and infertility. And the most common cause of death is your cardiorespiratory complications. Now, yung SIDS, skip natin kasi medyo low yield naman yan, but I will leave that for you to read. Now, let's go to tumors. Now, yung tumors, ito yung mga most common, no? Hemangioma, most common tumors of your infancy. Ang teratoma na most common ay sacrococcygeal. Now, the most common malignant is your leukemia. And ito yung sinasabi kong blastoma, no, doon sa chapter 6. Now, your tumors, no, there is a group of tumors in your pediatric age group called the small round blue cell tumors of your childhood, and these are formally called blastomas. Okay, so yun lang ang tatandaan nyo sa morphology ng mga small round blue cell of tumors, small round blue cells. Okay. So first off is your neuroblastoma. It's the most common extracranial solid tumor of your childhood, no? And the most commonly diagnosed malignancy of your infancy. So these are the genes that are involved. MYC-N is the major oncogenic driver. So clinically, these patients will present with an abdominal mass, no? Usually it crosses the midline, and when you have an advanced stage, you can have cutaneous mets, and you will have a blueberry muffin like rash, no, yung itsura. Kaya blueberry muffin baby yung itsura. And you can also have a lot of paraneoplastic syndromes like your opsoclonus, myoclonus, vipoma, etc. And these are the distant mets sites. Okay? Now, ano bang itsura ng neuroblastoma? Small round blue cells with homarite pseudo-rosettes. So, ang gitna nun is a pink neuropil or the fibrillary neuropil. Okay? And laboratory features, no? It's a tumor of the adrenal medulla, yung neuroblastoma, and it's therefore not uncommon, no, to produce catecholamines, kasi yun naman talaga yung pinoproduce ng adrenal medulla. So isa yon sa mga makakatulong sa inyo, no, to check for the presence of neuroblastoma. Okay? Now, for your nephroblastoma, or more commonly known as your Wilms tumor, it's the most common primary renal tumor of your childhood. Now, we have WT1 and WT2 mutations, and they're associated with respective syndromes. So, WT1, your Wagner and your Dennis-Drash, and your WT2 for your Beckwith-Wiedemann. Okay? And then, clinically, ang Wilms, meron ka ding abdominal mass. Usually, it does not cross the midline, but when they get large, they cross the midline, no? And meron silang renal manifestation, so may hematuria, no, na hindi mo nakikita sa neuroblastoma. So, ang morphology nito, classic, triphasic. Now, the rest is nice to know. Yung classic triphasic tumor niya ay best, no? You have your B, blastema, the small round blue cells. Your epithelial can be in the form of tubules or glomerular structures. And stroma can be fibrous or myxoid. So, here, we have an example of your Wilms tumor. Yung arrow, yung mga small round blue cells. And if you look, no, sa taas, meron pang mga rosettes dyan, no? Parang homarite yung itsura. And then, yung gitna niya, you have your tubules. Yan yung epithelial component. And then, yung background niya is a myxoid or masipon, yung itsura. No, myxoid stroma. So, you have the classic triphasic. So, that's your nephroblastoma. And that ends your pediatric path.